Okay. Yan. We are currently live streaming via the top-notch portal. So everybody just make sure that you have a good internet connection. Before we start tonight's session, let us all pause and say a little prayer. So sabihin niyo lang ako, guys. Is a prayer before studying. Is a hope prayer. So, God of miracles, I have many fears and doubts as I approach my exams. Please take away these negative thoughts and fill my soul with hope. I have worked hard and studied hard. I have walked with you during this preparatory journey. I have trained my mind diligently. I have said no to distractions and doubtful feelings. Please remind me that I am capable and hopeful of the outcome of these exams. I know that through hope, I can find success in these exams. In Jesus' compassionate name, amen. So, good evening, everyone. Good evening also to the students who are currently watching via the top-notch online portal. So, hopefully clear naman sa inyo no, yung audio. Clear naman, guys, no? Ah, okay. So, for tonight, so guys, I hope that you have already had your dinner na. Tapos, prepare na kayo nung quiz, yung 1/4 sheet of paper for the Quizmaster session tonight. So we are already on our fourth subject, surgery. So for tonight, we'll be having surgery summary lecture and Quizmaster session. So I will be introducing our speakers for tonight. Our first speaker is a graduate of the University of St. LaSalle, Bacolod City. He ranked second during the November 2020 physician licensure examination and currently a surgery resident in training at CLMMRH. So to give us a summary lecture for surgery is Dr. Patrick Mabugat. This will be followed later on by a graduate of the University of the Philippines, College of Medicine. He graduated as magna cum laude of his batch. And he's a top notcher of the October 2022 physician licensure examination. To give us the quiz for tonight is Dr. Justin Adriel Zent G. Togonon. So first of all, I would like to call on Dr. Patrick A. Mabugat. Doc.
Patrick, hello, good evening, Timmy.
Hi, good evening, Doc Rolly. Happy birthday, sir.
Yeah,
Happy birthday, sir. Good evening, everyone.
Buong araw, inaano ko, yung anak namin ng inaalagaan. Anyway, we have a very good combination for you for surgery for everyone. I've been reading the feedback. I've asked around the students for their experience with surgery. Magaling talagang teacher si Dr. Lubomir Antonio. Okay, Barnard, sinabi ko sa inyo naman at orientation pa lang, siya ang pinakamatalino sa aming lahat. And probably nakita niyo yan if you've listened and watched his lectures for the past few days. Okay? Ngayon guys, kung si Dr. Lubomir Antonio ang Michael Jordan ng surgery, ang Lebron is basically si Pat Mabuga. Kaya kung mapapansin ninyo, sinet namin na ang main lecture ninyo, almost running for almost 24 hours total lecture video time, si Dr. Lubomir Antonio. Pero yung pearls, okay, yung basically version natin ng final coaching, yung pearls, and yung summary lecture nyo will be given by Dr. Patrick Mabugat. Maganda yung combination nila guys. Magaling din tong si Pat. Okay? There are, if you're going to notice, medyo iba, may mga certain factual differences between the video lectures and the handouts. The reason for that is the handouts was updated not only by Dr. Lu, but also by Dr. Pat Mabugat, by Dr. Ann Cocos, Dr. Kurt Caspera. So multiple people work on that handout. It's much more updated actually compared to the lectures ni Sir. Okay, so medyo mamaya, medyo intensive yung ibibigay kong mga clarifications. Okay, regarding the handouts and the video. So watch out for that. We'll do it before your Quizmasters for tonight. May mga humabol pa. May mga nag-message pa kanina ng some clarifications. Halos umabot ng 50 yung clarifications na pinapatanong ng mga estudyante. About 30 of them, additional 30 were repeated, but 50 were unique clarifications. So we'll be addressing most of them later. Yung mga hindi pa nasagot ni Doc Lu, kasi today lang tinanong yung iba eh. Susubukan kong habulin by tomorrow. So just listen to that. Okay, I'll give you time to write. Okay. Kimi, pakisabi rin sa lahat ng MGs ha. Pag hindi ako halimbawa yung nagbigay nung para dun sa mga clarifications, yung quality assurance, you need to give the students time to write on their main handouts, to write some notes regarding those clarifications. So wag mag-proceed immediately to the next slide. Okay, so I'll set the pace mamaya. We'll do it after the summary lecture. So itong summary lecture na to is not supposed to be a replacement for the main lectures ng Top Notch. Never do that. Okay? I'll give further instructions regarding this. Kasi yung iba, sinusubukan ng nagpapaka-street smart na. So sinusubukan makahanap ng off-label use kung paano gagamitin yung handouts and videos. I'll tell you what to do by tomorrow regarding this para hindi kayo mapariwara sa tamang landas. Okay? So let's go back. Okay, Dr. Pat Mabugat, it's your show. Dr. Kimi, your show. Thank you so much. I'll see you later. Okay, sabihan niyo ako, Kimi, pag malapit na matapos si Doc Pat. Okay?
Yes, Doc. Thank you, Doc.
Thank you, Doc.
Doc Pat. You may share your screen.
Doc, can you allow me po to share my screen?
Ayan, Doc. Doc, it's okay. Yeah.
Can you see my screen na po?
Yes, Doc.
Okay na. Sige. Should I start, Doc? Okay na.
Yes, Doc. Thank you.
Okay. Good morning, everyone. Good evening na pala, sorry. I just came out of 48-hour duty. And when you go into residency, you need to devote all your time into your patients, into your duties. That's why it's sometimes difficult to squeeze in extracurricular activities. But I always make sure that I give time for you guys. This is my honor actually as also an alumni of Top Notch to share what I've learned with Dr. Lumir. So before I start, I graduate medical technology in the University of Negros Occidental here in Bacolod. I took up med school in University of St. LaSalle here in Bacolod. The place of Mascara and Chikinanasal. I did my postgrad internship in PGH, and I took the board exam last November 2020, and I was fortunate enough to pass. Currently, I'm taking up surgical residency as GS here in Quezon, Locsin, which is the regional hospital of our province, and I'm currently on my third year. But again, tonight, I am just very honored. Tonight, not morning. I'm just very honored to be of service to you guys. Nothing would make me happier than to share what I have learned throughout the years with you guys, in the hopes that in the future, we'll be the ones teaching the later generations. Okay, so this lecture will be very, very comprehensive in a span of 90 minutes. So I might be a bit fast at certain times, but I'll do my best to pace myself out. So this will be a rapid fire, something like a quick review session of everything that Dr. Lubomir has taught you. So Dr. Lubomir has also been my teacher, and I could say that everything that he taught was more than enough for your board exams. Okay, so without further ado, let's start. So what's the total body weight constituted approximately by water? So actually, to answer this question, you need to identify the demographic of the case. So if it's adult males, it's 60%. If adult females, it's 50%. The reason why adult males have a higher percentage body water is because males generally have higher lean muscle mass. Muscle holds most of the water in the body. Conversely, in females, females have a higher content of adipose tissue. Just remember that oil and water don't mix. Okay. In an average 70 kilogram male divided by 60%, that's 60% males, males are actually composed of 42 liters of water. Newborns are made up mostly of water, so they're just actually moving bags of water. That's 80%. Obese people have lower adipose content because they're made up of 10 to 20%, and malnourished people are adjusted upward by 10%. On average, what's the percentage of body weight accounted for by blood? That's, sorry. We again share another slide. This is an old PowerPoint. Wait lang. Let me bring it up. Thank you, slide. Sorry for the technical difficulties, doctors. We'll just bring up the slide. Sorry, take two. Sorry guys. Iba talaga pag FD. Okay, again. For adult males, they have a higher percentage body water because in females, they have higher adipose tissue, and oil and water don't mix, which is easy to remember. Obese people having higher adipose content, having higher fat, having higher oil, have less water. So their total body water is adjusted downward by 10 to 20%. Malnourished people have their body weight, total body weight water adjusted upward by 10% because they have less fat and more muscles. Okay, so in average 70 kilogram male, 60% of the body weight of that male is made up of water. So that's 70 times 60, that's 70 times 0.6, that's 42 liters of water. On average, what's the percentage body weight accounted for by blood? That's 7%. 70 kilograms times 7%, that's 0.07. You have 5 liters, okay, 5 lits. Easy to remember, blood has 5 liters. Average human male has 5 liters. Okay. Now we have this diagram right here taken from Schwartz, showcasing the different body compartments of water. A good mnemonic I have for this is TI 60-40-20. Thai is total body water. Again, in adult male, it's 60%. Now, the total body water is divided into intracellular and extracellular. Now, most of which are found inside your cell to maintain your homeostasis. So 40% of your total body water is actually inside your cells. 20% is outside the cell. Now, outside the cell, it can either be found in tissues, your interstitial fluid, which makes up 15%, or inside your plasma, inside your blood vessels. So that's 5%. The next high-yield question, what's the most common fluid disorder in the surgical patient? It's extracellular volume deficit. The reason for this is that cells would always try to maintain homeostasis. So the water content inside the cells is usually constant. It tries to prevent any changes. So the first to adapt is actually outside the cell. So that's extracellular volume deficit. Especially in newborns, this is very evident by sunken eyeballs, decreased skin turgor. However, in older adults, they usually present neurologic signs, GI signs such as confusion, abdominal pain, abdominal discomfort, among others. What's the most common cause of volume deficit in surgical patients? The most common cause of volume deficit in surgical patients is the loss of GI fluids, either by NGT suctioning, vomiting, diarrhea, or enterocutaneous fistulas. So again, volume deficit in surgical patients is truly loss of GI fluids. Next, high-yield question. How many mEqs of potassium is contained in 1 liter of NSS? So think hard. So this is actually a trick question. You don't have any potassium inside your plain NSS. Again, plain NSS, you only have saline, which is composed of sodium and chloride. So this table showing the two most common crystalloids which we use in surgery, your LR and NSS, is compared against your ECF. As you can see, your LR is the one that highly closely resembles your extracellular fluid. However, we have newer fluids which actually have almost the same content as your extracellular fluid. We have your osmolyte. But the point of this question is just showing you that NSS only actually has sodium and chloride and has 0 potassium. So don't get tricked. Plain NSS, 0 mEqs of potassium. Now, what's the acid-base balance of fluids? Now, lactated ringers, if you think about it, we're going to think lactate is acidotic. But actually, giving plain LR in patients would push them forward into alkalosis. Plain NSS, conversely, pushes you into acidosis. Okay, now LR, alkalosis, why is that? Your lactate there is not just lactate, it's sodium lactate, and it's preferentially pushed into bicarbonate production. Remember, hydrogen ions is acidotic, bicarbonate ions are alkalotic. So if you have more sodium lactate, more sodium bicarbonate, it increases the pH, pushing the patient into alkalosis. This is different from your NSS. Now the NSS, the increased chloride being negative, pushes the bicarbonate. Remember, bicarbonate is usually found outside the cell. If there's increased chloride, it's going to push the bicarbonate inside the cell, thus decreasing the bicarbonate levels in the blood. If you have less bicarbonate in the blood, you have acidosis. So there's decreased pH. Again, don't get confused. Lactated ringers, alkalosis, NSS, acidosis. Next, what's the fluid that may be used to replace high NG tube output? It's your NSS. Okay, why? What's very helpful is this diagram, is this summarized table right here, taken from Schwartz also, which shows that your NG tube is actually coming from, most of the fluids are coming from the stomach. In the stomach, one of the significant electrolytes found there is your chloride. Okay? Remember, between your plain LR and your plain NSS, which has higher amounts of chloride, your NSS. Next, for diarrhea. So diarrhea, we're going to think colonic fluid. So in the colon, you have high amounts, significant amounts of potassium. You need to replace it with the only fluid that has potassium, your LR. Or you may include NSS, but you may incorporate potassium collection with it. How about bile fluid? Bile comes from the liver, comes from also from the pancreas. If you can see, as highlighted here in the table, your pancreatic fluid and your bile fluid both have increased levels of bicarbonate. So among the two which has bicarbonate, remember that your lactated ringers, the lactate there is converted into bicarbonate. Or you can use D5 with bicarbonate. What's the average sodium needed per day? That's 1 mg per kg per day. How about potassium? So easy way to remember, sodium has 2 letters, potassium has 1 letter, sodium is 1, potassium divided by 2, you have 0.5 mg per kg per day. So sodium 1, potassium 0.5. Okay? Next, let's talk about nutrition. What's the most abundant source of energy during short-term fasting? So I know most of you are going to answer glycogen, but this is actually a trick question. It has been asked multiple times in the board exams. It's actually your lipids. This is taken verbatim from Schwartz. Okay. I think the confusion here lies that we know that glycogen is usually used for short-term fasting, but the question is specifically asking for the most abundant source. So if you can see in this diagram right here, glycogen only has 75 grams to spare in an average 70 kilogram meal. However, your fatty acids, your triglycerides can contribute somewhat around 120 grams of fatty acids. And remember, for each gram of that, it's converted to its respective caloric product. If you review your biochemistry or your physiology, we remember that carbs and proteins only give 4 kcal or calories per gram, while your fats give off 9. So again, most abundant, most efficient actually of them all are your fats. So here's a summarized table taken from Schwartz also. Short-term fasting, lipids. Prolonged fasting, especially in the brain, we have your ketone bodies, and after injury, it's lipids. So lipids, fasting, brain, ketone bodies in prolonged fasting. Next, 16-year-old female with anorexia nervosa started on high-caloric parental nutrition, suddenly developed confusion, dyspnea, and irregular heartbeat. What's the most likely diagnosis? So patient has been chronically starved, and you feed them high-caloric nutrition again, you feed them. So that's refeeding syndrome. Now, why is feeding a patient who is starved problematic? This is because of the hormonal response of your body. Her body is starved of calories. If you suddenly push high amounts of calories there, your body is going to get very eager. It's going to increase the production of your insulin. Okay? Insulin does not only push glucose inside the cells, it also pushes the electrolytes around the glucose with it. So the electrolytes involved, we have your potassium, phosphorus, magnesium, and sometimes in other references, we have calcium. But for the board exams, this has been asked before, just remember ppm, potassium, phosphorus, and magnesium, sometimes calcium. Okay. Potassium, phosphorus, magnesium can cause neurologic disturbances, cardiovascular, muscular disturbances. But in the case, chronically starved, refeed them again, it's probably refeeding syndrome. What's the vitamin given prior to feeding? So the vitamin given prior to feeding is your vitamin B1 or your thiamine. Now, the reason for this is that thiamine actually helps in glucose utilization. It actually plays a part in the uptake of glucose and the utilization of glucose. However, another important thing is that in chronically starved patients whom you actually give high caloric nutrition immediately, you can push the patient into Wernicke-Korsakoff syndrome. What's Wernicke-Korsakoff? So Wernicke-Korsakoff, you have confusion, ophthalmoplegia, ataxia, and thiamine deficiency. That's Wernicke, that's coat. The name for that is coat. For Korsakoff, you have retrograde and anterograde amnesia, confabulation, and Korsakoff psychosis. That's coat rack. Okay. Wernicke-Korsakoff, the name for there is coat. For Wernicke's Korsakoff, that's rack. That's coat rack for Wernicke-Korsakoff. Next, what's the parenteral nutrition that can deliver higher dextrose content? So you only have actually 2 types of parenteral nutrition. Parenteral means not enteral or beside enteral. So we're thinking of either peripheral or central. When we say peripheral, we make use of peripheral lines. If central, we make use of central lines. So higher dextrose content, of course, you utilize larger veins. So the differences, so for central, you have higher dextrose content. For central, you can give higher osmolarity feeds. Again, the access for central is large diameter central veins. One good example would be your internal jugular vein. And the duration, you can give it longer. As compared to peripheral, which you can give lesser dextrose, less osmolarity, and less length of time. Next, What's the most common serious complication of TPN use? The most common serious complication of TPN use is sepsis, secondary to contamination of the central venous catheter. This is not only exclusive to TPN use. Every time you use a central venous catheter, you always have to think of possible catheter-related infection, possible sepsis from that. So what's the earliest sign according to Schwartz? The earliest sign is sudden development of glucose intolerance in a patient who previously has been maintained on parenteral alimentation. So what's the criteria for sepsis? So sepsis has actually evolved over time. You have a first criteria for sepsis, the historical one, then is evolved into the sepsis 3 later on. But for the purposes of the board exams, we just need to understand the historical or the original descriptions of sepsis. So sepsis is SIRS plus a presumed source of infection. So SIRS actually has 4 variables. For sepsis to qualify, you only need to have 2 out of 4. So for the SIRS criteria, we have 2 or more of the following. We have temperature more than or equal to 38, less than or equal to 36, heart rate more than or equal to 90 beats per minute, RR more than 20 per minute, or PCO2 less than 32. The reason for PCO2 being less is because, remember, if you have tachypnea, if you're breathing more, carbon dioxide is being expelled out more. So you're going to have less PCO2. For WBCs, it's either going to be more than or equal to 12,000, leukocytosis, or you can also have leukopenia less than or equal to 4,000. The reason for that is that in severe infection, remember, the WBCs gets exhausted. So it can either go up or go down in cases of sepsis. One thing to remember is that there is no BP in the SIRS criteria. So a good way to remember that is walang BP si sir. Okay, walang BP si sir, no BP in SIRS criteria. So actually, description of your infection, sepsis, SIRS is actually a spectrum, right? So we've already discussed infection, SIRS, and sepsis. Let's discuss severe sepsis and septic shock. Severe sepsis, when you have sepsis plus organ dysfunction. It may either be AKI, renal, it may either be neurologic, it may either be pulmonary. So that's severe sepsis. Septic shock, however, is different from severe sepsis because there is already cardiovascular collapse as presented by hypotension. Septic shock, hypotension. But this hypotension needs to be qualified by the requirement of vasopressor support. So your patient is already on inotropes, then you're probably thinking the patient is undergoing septic shock. Now, this is the old one. Later on, we have the sepsis 3 guidelines, which actually makes use of the SOFA criteria. I think that will be discussed more in depth in your internal medicine lecture. For the purpose of surgery, we just need to know the Q-SOFA score. The Q-SOFA score is actually a predictor, not a criteria really, of patients who will deteriorate and who will have severe sepsis later on. So it's usually a helpful triaging tool. So for Q-SOFA, we have 3: hypotension, altered sensorium, and tachypnea. Hypotension less than or equal to 100 millimeters mercury, altered sensorium less than or equal to GCS 14, and tachypnea RR more than 22. Sepsis, that's 20 RR. For Q-SOFA, that's 22. A good mnemonic for that is that there's a hat on top of the sofa. Hat, hypotension, altered sensorium, and tachypnea. Next, what's the first-line vasopressor in sepsis? According to sepsis guidelines, the first-line vasopressor in sepsis is your norepinephrine. Okay, norepinephrine. Other vasopressors that you may use are your epinephrine and your dopamine. Okay, so if you're already using triple inotropes, norepi, epi, dopamine, and if for the board exam purposes, or if you want to be pabibo to your consultants later on or your attendings later on, you suggest, Doc, what if we use steroids? Well, that is actually a valid suggestion because according to sepsis guidelines, if you're already exhausted, your 3 inotropes, you can add hydrocortisone because some of these patients have what we call your CIRSE. CIRSE stands for critical illness-related corticosteroid insufficiency. So in patients who are undergoing shock, they usually have adrenal insufficiency, which is incapable of meeting their daily demands. If you add hydrocortisone, sometimes the vasopressors will take into action. Okay? Next, what's the initial resuscitation rate in adults with hypotension? The initial resuscitation rate in adults with hypotension are your crystalloids, 30 cc per kgs. Again, in adults with hypertension, we make use of crystalloids, 30 cc per kgs. But take note, in newer guidelines, in more recent conferences and panels and discussions, the first line actually now is blood rather than crystalloids. However, that is not applicable for every institution, and according to the sepsis guidelines, they make still use of your crystalloids. Just a side note, for pedia, crystalloids for initial resuscitation, that's 20 cc per kgs. For blood, that's 10 cc per kgs in pedia. Again, adults, 30 cc per kgs. Pedia, that's 20 cc per kgs. Blood, pedia blood, that's 10 cc per kgs. Okay. Next, what refers to the presence of organisms on the surface of a wound? The presence of organisms on the surface of a wound is what we call your contamination. Surprisingly, questions sometimes as simple as this come out in the board exam, especially in our time. We even have questions pertaining to halitosis and gingivitis in surgery. So there's questions like this that sometimes will put you off your momentum, but try to keep track of your pacing and try to not overthink some of these questions. So this one is taken from Junqueira. Contamination refers to the presence of organisms on the surface of a wound. This occurs before multiplication. Colonization refers to the presence of multiplying organisms. Contamination, it's just there. Colonization, they're multiplying. But both contamination and colonization do not exert a host response. They're just there. They're not interfering with your immune system. They're not eating off your skin, your organs. They're just there. There comes a point where we call it critical colonization, which is the point at which host defenses are unable to maintain the balance of organisms. After critical colonization, that is where we have your infection. Infection is where we have already a host response. Like again, contamination, colonization, no host response, infection with host response. Next, what's the most common cause of fever on post of day 1? Now, this is very controversial. Atelectasis. Now, my disclaimer for this, for the 5 W's of post of fever, is that some authors, some studies suggest that the original 5 W's of post of fever are actually anecdotal. They don't have much body of evidence to prove them. However, in the board exams, this has been popping out every other year. So I guess even though we can't really trust the 5 W's of post of fever, I think it's very helpful to know for board exam purposes only. So it's the 5 W's. We have wind, water, walk, wound, and wonder drugs. So for wind, we have atelectasis if less than 48 hours. If more than 48 hours, we're thinking of pneumonia. So atelectasis or pneumonia. That's why in patients post-op, you suggest incentive spirometry sometimes. Next is water, UTI, which usually lasts 3 to 5 days. So actually, there's a question, what's the cause of UTI in post-op patients is usually the presence of a urinary catheter. You remove it, and usually treat empirically, and it resolves by after a few days. Walk, DVT, so patient who has been post-op, bed-bound, remember the well scoring in IM, usually have higher predisposition to venous thrombosis. That's why we sometimes give enoxaparin, we sometimes give, we use compression stockings in patients who are post-op. For wound, we have SSI, and for wonder drugs, usually medications. So 48 hours, wind, water, 3 days, walk, 5 days, wound, 7 days. So there's a 2-day gap in between, okay? Wonder drugs, more than 7 days or sometimes, depending on what kind of drug you use. So for UTI, more than 10 raised to the power 4 CFU per ml in symptomatic patients. And for asymptomatic patients, it's 10 raised to the power 5 colony-forming units per ml. This is your urine culture. Next, patient underwent laparoscopic appendectomy. Pre-op CT reported appendix contained a fecalith. There was no mention of infection, rupture, inflammation in the op report. What's the class of wound? So we have 4 classes of wounds. We have clean contaminated, we have contaminated, and we have dirty, right? So 4 classes. This question is asking which class does this case belong? So LAP, AP, no infection, rupture, inflammation. So the 4, what's the answer? The answer is class 2, clean, contaminated. So we have a table right here, clean, clean, contaminated, contaminated, and dirty. Okay, just to go over this very effectively, I'm going to discuss this table right now. For clean, there is no entry into the genitourinary, GI, or respiratory tract. So you don't enter anything hollow, right? So hernia repair, just open skin, you don't enter anything, you push it back in, it's clean, it's class 1. Breast surgery, just remove the breast, that's class 1. However, if you enter something, the GU, GI respiratory tract, okay, such as cholecystectomy, elective GI surgery, then it becomes clean, contaminated. There's another separate subsection for colorectal surgery, which is actually still under class 2, but has higher amounts of infection, right? So that's why there's a separate row for colorectal surgery there. For contaminated, that's where there is entry and there is inflammation. So there's introduction of bacteria due to major breaks of sterile technique and inflammation, such as in penetrating abdominal trauma, large tissue injury, or enterotomies. For dirty, there's overt infections. There's pus, there's abscess, there's necrosis, or necrotizing infections. That's dirty, right? So for this patient, AP was done, you enter the viscous, it's not inflamed, it's not purulent, there's no necrosis, there's no abscess, you remove it, that's clean, contaminated, that's class 2. Next, patient underwent lap AP. The operative report states it was an inflamed appendix. What's the class of wound? So again, if there's inflammation already, it's already class 3 contaminated. So again, class 1, that's clean, there's no entry in any hollow viscous. Class 2, there is entry, but still somewhat clean. Class 3, there's inflammation. Class 4, there's pus or there's abscess. Right? For this one, it's only inflamed, right? So inflamed appendix, according to Schwartz, also includes perforated or gangrenous. Why? Because Schwartz considers only periappendiceal abscess or those with generalized peritonitis to be dirty. So for an appendix who has just ruptured or is just gangrenous by itself and you remove it, that's still class 3 contaminated. However, if there's pus or there's abscess, that's where we go into your class 4 or dirty. So lap AP, there's periappendiceal abscess, this is class 4 or dirty, right? Okay, so again, just to emphasize, class 1, there's no entry, class 2, there's entry, class 3, it's inflamed but non-purulent, class 4, it's purulent or with abscess. So easy to remember, right? Next, patient, post appendectomy a year prior, went to your clinic complaining of abdominal pain. CT scan revealed a small bowel obstructions. You're thinking post-op adhesions, right? The most common. XLAP was performed and adhesiolysis frees up the obstruction. What's the class of wound? So I'll give you a few seconds to think about this, right? So you operated the patient, you adhesiolyzed the patient. Did you enter any bowel? Was there inflammation or purulence? No. So the correct answer for this is still a class 1 or clean, right? There's no entry of anything, it's clean, there's no inflammation, there's no purulence. So at first I was confused also, but yes, the purpose of this is I want you guys to be better than me. So I want you at this point to understand differences between these things, and I want you to understand it in a simple way that you can take into the board exam and not just brute memorize everything. Next, fibroblasts and endothelial cells infiltrate the wound to reestablish tissue continuity. PDGF is the strongest chemotactic factor for these types of cells. What's the phase of wound healing described? So we actually have 4 to 5 phases of wound healing, depending which reference you use. Even Schwartz has different numbers of wound healing, depending if you place it in the table or it's in the paragraphs. But generally, we have these 4 main groups of phases. So we have hemostasis and inflammation, we have proliferation, we have maturation, remodeling, when you have epithelialization. So first, you have an injury. Of course, it's going to stop bleeding first. Then your inflammation comes into play. We have first your neutrophils, which are the first responders, followed by your macrophages and your lymphocytes, which actually bridge the gap between inflammation and proliferation. right? Next, proliferation. What proliferates? So what proliferates are the scaffolding materials and the cells that make those scaffolding materials in the wound. So we have your fibroblasts and endothelial cells. So the chemotactic factor for them is your platelet-derived growth factor. So when platelets go in, they cause hemostasis, they release this growth factor, signaling the endothelial cells and fibroblasts to go in and start producing collagen. But what collagen are they producing? They're only producing the framework collagen, the scaffolding collagen. This is your type 3 collagen. Because later on, that type 3 collagen is going to get remodeled into your stronger and better collagen fibers. That's your type 1 fibers. Now, the enzyme useful for this in your maturation, your modeling phase are MMPs, or matrix metalloproteinases. After a while, we finally go to the last phase, the epithelialization phase. Epithelial cells will migrate and cover the wound. And sometimes, if there's perfect tissue repair, it's like nothing has happened. So that's epithelialization. Next, a 30-year-old male sustained a large injury over his thigh after a dog bite. The wound was left open for 5 days, then closed with sutures. What's the type of wound healing? So there's 3 types of wound healing: primary, secondary, and tertiary. Okay. So for this question, the answer is tertiary intention. While for primary closure or primary intention, primary means you close it immediately. There's a wound there, it's a clean incision, you close it immediately after. That's primary intention. Secondary intention is when you let the body do it secondarily. You let the body heal in itself. So you leave it open and you let it heal by granulation. You usually do this in patients who have contaminated wounds, right? But if you have severely contaminated wounds, such as those occurring from dog bites or from traumatic injuries or laceration with foreign bodies, we do tertiary healing. What's tertiary healing? Tertiary healing is actually a combination of 1 plus 2. That's 3, right? Combination of primary and secondary. So what is tertiary healing? You let it open, let it heal by itself, you let it granulate, and until such time you can see it's already clean, granulation tissue is already healthy, you try to close it up. So that's tertiary healing or delayed primary closure. Next, what's the first priority in your primary survey? So primary survey, how many components do we have? We have 5. We have your A, B, C, D, and E. Okay. Actually, I've added 1 recently, exsanguination, but that's not important for board exam purposes. Okay, so what's the first priority in the primary survey? So that's A, B, C, D, E. The first priority is ensuring a patent airway. A comes first before everything. But again, recently we have exsanguination. But for board exam purposes, airway is first. No, it's not only airway, because ensuring a patent airway is not enough if the cervical spine is unstable. So you need to stabilize your cervical spine by using your collars or using specific positioning techniques to make sure that the neck does not get moved too much, especially in patients with brain trauma. Next, this one has come out of board exams a few times. What's the most common indication for intubation? Most common indication for intubation is an altered sensorium. So we have the old adage, GCS8, intubate, right? GCS8, intubate sounds good. But recently they've added GCS8, wait, then intubate. What is wait? Wait is when you need to assess first, you need to correct first if there's acidosis, if there's hypoglycemia. The patient is actually an alcoholic. Sometimes they get intubated because they think they have brain trauma, right? So GCS wait and intubate is a good way to remember that in severe traumatic injuries, which are GCS8 or less, we need to intubate these patients immediately. What are the components of the secondary survey? We have the AMPL. So AMPL stands for allergies, medications, past medical history, last meal, and events surrounding the injury. Okay? Now, corollary to this is there's a question one time which asked, what's the most common obstructing object? So the most common obstructing object, actually, the reason why you need to intubate patients with altered sensorium is because usually they have poor reflexes, they have poor response to aspiration, and sometimes the tongue falls back to itself. So it's actually the tongue, the most common cause of obstruction. So you intubate these patients to protect their airways. If there's a foreign body, what do? If there's injuries, there's foreign body, there's something lodged inside there, the most emergent that you can do is a cricothyroidotomy. Next, 30-year-old male, slip, hit his head on the gutter. On assessment, the patient opens his eyes to speech, speaks inappropriate words, and localizes pain. Usually, they have 1 or 2 questions in the board exams regarding GCS score, and they usually ask you to solve the GCS score. So if you don't memorize the table, you're gonna get confused. Okay. So for this one, eye-opening speech, that's E3. Speaks inappropriately, that's V3. And localizes pain, that's M5. We have a score totaling to GCS 11, E3, V3, M5. So we have the old GCS score here. All I say because this has been recently updated into your GCS 40. Not because there's 40 variables or there's a perfect score of 40, but the GCS score was revised on their 40th anniversary, right? Okay, this simplifies everything. For eye-opening, the lowest score is 1, the highest score is 4, 2 is to pressure instead of to pain, and 3 is to speech as compared to sound. Why pressure? Because sternal rubs, albeit are very kind of not very welcoming to see. So we actually made use of the trapezius pinch, the supraorbital pressure, and the pinching of the nail bed to simulate pressure in the patient, not pain necessarily. And for 3, to speech. For verbal response, we have non-sounds, words, confused, and oriented. For best motor response, basically still the same. So lowest score you get, that's 3. High score you get, that's 15. Again, for eye-opening, non, pressure, speech, spontaneous. Verbal response, non, sounds, words, sentences but confused, sentences but oriented. So this easy way to remember your verbal response. For motor response, you have extension, you have non-extension, flexion, withdrawal, localizing, and obeying commands. That's 6 in total, right? Still, in the topic of neurotrauma, we have epidural and subdural hematomas, which are very high yield also in the board exams. So this question actually came out in a recent board exam. What hematoma is identified beneath the inner dural layer? So we have epidural and subdural. As its name suggests, epi is above, sub is below. So beneath the dural layer, you have your subdural hematoma. What's the shape on CT scan of your subdural hematoma? Hey, please try to follow my gesturing here. Okay, imagine this is bone. Below bone, you have dura. Below the dura, you have brain tissue, right? Dura, above it, you have your epidural. Below it, you have your subdural. Your subdural is below your dura, and below it is your brain tissue. Brain tissue is soft, it's movable. So if there's a hematoma here, the hematoma is just going to spread outward. It's going to look like a crescent shape, right? It's just going to spread outward. For the blood vessel involved in subdural hematomas are the blood vessels that are actually very soft, very friable, very thin, right? Because it's just dura and brain tissue here. Every time the brain moves too much, some of these vessels is going to get ripped out. So these are your very thin, very friable, very fragile bridging veins, okay? How about above the dural layer? We have your epidural hematoma. Epidural, above. What's the shape on CT scan? Remember, this is bone, this is dura, this is brain. Epidural above the dura, but below bone. Remember that the dura is actually very closely adherent to bone. It's stuck on bone. If there's a hematoma there, it's only going to get peeled little by little, okay, forming a somewhat lenticular or lens-shaped form, right? It's just going to get peeled off little by little because it's stuck to bone, right? Now, what's the blood vessel involved? Remember that the blood vessel that can overcome the pressure of of a dura sticking to bone, the blood vessel that can only push the dura downward needs high pressure. So it's actually an artery, and one of the more common arteries is the middle meningeal artery, right? Easy way to remember subdural and epidural. Which of the two, however, does not cross suture lines? This also has come in the board exams. Remember, suture lines are your lines of your cranial bones, right? The dura is stuck on those cranial lines is stuck on bone. So which hematoma does not cross the suture lines? That's your epidural hematoma. Next, does not cross the midline. That is your subdural hematoma. The reason for that is, as remember, this is the calvarium. You have the illustration there, but I like gesturing so that I can visualize the explanation better, right? You have your skull here, right? You have reflections of dura splitting the calvarium generally into two portions, right? With your corpus callosum here, you have your two hemispheres here, but there's one dural reflection here. Dural reflection we call your fox cerebri, right? So the dural reflection here splits actually your two hemispheres. So if there's hematoma here, and the hematoma is just between the dura and the brain tissue, it's just gonna get trapped in one side. It's not gonna go to the other side. So the one that cannot cross the midline because there's a fox cerebri is your subdural hematoma. Again, suture lines, epidural, it cannot cross because it's stuck on bone. Subdural, it cannot cross because we have a fox cerebri. Okay. Next, what's the sign that qualifies a pneumothorax as a tension pneumothorax? A tension pneumothorax is only qualified by the presence of hemodynamic instability or your hypotension. Tension. What is your pneumothorax pushing? It's pushing your mediastinum to one side. If there's hematoma, if there's pneumothorax here, it's going to push the lungs here, it's going to push the mediastinum here. As a result, your vessels are going to get occluded. So you're going to have hypotension from these patients. So what we do needle decompression if emergent. So needle decompression historically has been making use of the second ICS, mid-sternal line, second ICS. However, more recent studies have shown that the fourth to fifth anterior axillary line is the best place to do a needle decompression. Needle, not thoracostomy, needle only. It temporizes and allows you to prepare materials for a formal thoracostomy, right? So when you do a tube thoracostomy, a closed tube thoracostomy, or chest tube thoracostomy, you make use of what ICS, this has been popping out also in the board exams, your mid-axillary line, fourth to fifth ICS. So that's the best place, right? Okay. For pneumothorax, actually, it doesn't matter. Wherever you try to put a needle, put a chest tube, it doesn't matter. It's going to resolve. However, for hemothorax, the fourth to fifth ICS provides you with a great vantage point not to hit any structures and also allows you to drain it properly if it's in the more dependent areas. It also allows for possible bats later on. You can put your ports there, right? Okay, again, needle decompression, previously second ICS, mid-sternal line, right? However, according to Schwartz, more recent studies, anterior axillary line, fourth to fifth, that's for needle decompression. That's best now recently. For CTT, or closed tube thoracostomy, that's mid-axillary line, fourth to fifth ICS. Next, what's flail chest? So flail chest is fractures in 3 or more ribs. That's contiguous ribs in 2 or more locations. So the ribs need to be following each other. So second, third, fourth, right? Those ribs should be contiguous. Then it's in 2 points. 2 points of the rib should be injured. Right? That's flail chest. Now, a flail chest is only problematic if it is a pulmonary contusion underneath. It's the pulmonary contusion which actually kills a patient with a flail chest, right? But if you have a flail, description of flail chest, but without a contusion, sometimes we call that only as a flail segment, not a flail chest. Next, for hemothorax, what's the indication for thoracotomy? In penetrating stabbing injuries, only 1 liter is needed. If it exceeds 1 liter on the initial drain, bring the patient to the OR. For blunt injuries, hammer, motor vehicle accident, you need to have more than 1.5 for you to qualify, bring the patient to the OR for a formal thoracotomy, right? We can also use the third criteria as 200 cc per hour for 3 consecutive hours for a formal thoracotomy. Other indications are as follows: cake hemothorax, tamponade, herniation, air leak, etc. Right? So you have sample cases right here. Stab wound, right chest, 1,200 ml initial output. So stab wound is penetrating, we require at least 1 liter. So this has exceeded your 1 liter. So then bring the patient to the OR, right? Next, hit by a pipe, left chest. Hit by a pipe, left chest, 1,400 ml initial output. We say that the criteria is 1.5 liters. This does not actually fulfill the criteria for bringing the patient to a thoracotomy. Bullet injury, right chest, first R 600, second R 100, third R 200. So, does not qualify. Why? Doc, 200 cc per hour. So in 3 hours, that's 600, right, Doc? So patient already had 600 the first hour. Do we bring the patient to the OR? Well, the criteria should be 200 cc per hour for 3 consecutive hours. So for the 3 hours that you've been observing the patient, each hour should have at least 200 cc. You don't need to exceed more than 600 in the first hour. If it's less than 200 in the second hour, it's not qualified, right? So for this one, 600, second hour 100, so did not qualify. Third hour 200 cc, so it's not consecutive. It does not follow each other. You don't need to bring the patient to the OR, right? You need to make sure na sunod-sunod, okay? First, second hour, third hour, more than 200. Next, dilated neck veins, muffled heart sounds, and declining arterial pressure. This is what you call your Beck's triad. Beck's triad is a somewhat sensitive indicator of a patient who's undergoing pericardial tamponade, right? What's the ml of blood that may cause a tamponade? It's usually less than 100 ml, okay, or 100 ml is needed to tamponade the heart, right? ml of blood that you need to remove to stabilize the tamponade is 15 to 20 ml. So in a patient who you're thinking of tamponade, you don't necessarily need to bring him to the OR to stabilize the patient. You can do pericardiocentesis bedside, subxiphoid approach, just to aspirate even as little as 15 to 20 ml or into Schwartz, so that the patient will stabilize somewhat before bringing the patient to the OR for an open thoracotomy and to examine the mediastinum. Next. 22 male, abdominal gunshot wound, heart rate 120s, R40s, BP 80-60, urine output 15 cc per hour. Class of shock, at least. Okay, so we have different parameters. We just need severe to most severe. For this patient, what's important to identify is that patient is already hypotensive. Okay, it's already hypotensive. And there's decreasing urine output. Remember that urine output needs to be at least 0.5 cc per kgs per hour. So this patient is an adult male. So patient should have at least 30 cc or 35 cc per hour. So for this patient, the patient has decreased urine output and has hypotension. This is already a class 3 shock. Hypotension, DPCO, that's class 3. Okay? Class 1, class 2, again, does not have hypotension, does not have decreased urine output. In percentage, what's the blood loss? Good way to remember this is for those playing tennis. I played tennis before, but I'm really not that good in the game, but I just know how to score in tennis. That's 1, 2, 3, love 0, 1, 2, 3, and the fourth score is the game, right? For 0, that's love 0. For 1, that's 15, right? So for class 1, that's up to 15%. For 2, that's 30. Okay. 2 is 15 to 30%. 3 is 40, that's 30 to 40%, and 4, that's game that's more than 40%. Okay, blood loss in percent, 15 to 30, 30 to 40, then more than 40. How about in ml? Well, a good way that we remember this is we just need to divide the percentage, right? So just think, for class 1, it's 15%. If you divide 15 by 2, you get 7.5. 7.5, 750 ml. Right? It's class 1. Class 2, 15 to 30. 15 divided by 2, that's 7.5. 30 divided by 2, that's 15. So what do we get? We get 750 to 1,500. Class 3, 30 to 40. 30 divided by 2, you have 15. 40 divided by 2, you have 20. That's 1,500 to 2,000 liters of blood. And for 40, that's divided by 2, that's 2,000. So again, if you memorize the percentages, begin memorizing the tennis scoring system, you just need to identify which class, which percent, then you divide it by 2, you get the actual blood loss in ml, right? Next, what's the approximate ml of blood loss in femoral fractures? It's 80 to 1,000 ml. Well, this is important because in patients who come to the emergency room and who are hypotensive, you need to identify the source of bleeding. Because if there's no other source of bleeding, you need to think of more internal causes, right? So you need to estimate the blood loss. So the patient who has a rib fracture, they usually lose 100 to 200 cc of blood. Tibial fractures is 300 to 500 cc blood. Femoral fractures, you get 800 to 1 liter of blood. And for pelvis, you get 2 liters of blood loss, right? Hey, again, just to recap, at what percentage do we get hypotension? It's class 3. Class 3 is 30 to 40. We need to lose at least 1.5 liters of blood before we get hypotensive, right? Right. So a solitary fracture of the rib, tibia, femur is not enough to cause hypotension. However, a pelvic fracture will cause hypotension because 2 liters is more than 1.5, and 1.5 liters of blood loss is one of the criteria for a class 3 shock, which is characterized by hypotension. Right? Next, what can cause can intracranial hemorrhage cause hypotension? So you don't find any injury in the patient, but you identified in CT scan the patient as an hematoma. Would you think that the hematoma in the brain can cause the hypotension? The answer is no. Why? Because the calvarium is only made up of blood, tissue, which makes up most of it, and CSF, right? But the calvarium can only hold 1.5 kilograms or 1.5 cc. So 1.5 with brain there, with CSF there, no matter how much blood you put in there, it cannot exceed 1.5. And again, 1.5 liters, 2 liters is the criteria for class 3 shock. You need to lose 1.5 liters for hypotension to occur, right? So intracranial hemorrhage, no matter how high, cannot cause hypotension unless patient goes to herniation later on, right? In general, BP for the carotid pulse be palpable. So you have the mnemonic CFR, carotid 60, femoral 70, radial 80. So the farther away we get from the more central, the carotid, femoral to the radial, the farther away we get, and the BP is appreciated, the more we can assume that the patient has adequate BP, right? So for a carotid pulse is palpable, you can see it's at least the patient has at least 60 BP, femoral at least 70, radial at least 80 millimeters mercury. Next, fracture of the proximal third of the ulna with dislocation of the radial head. So just a short, quick review. We have the Monteggia fracture. This is included in your handouts already. So Monteggia fracture, we have the mnemonic Mugger, M-U-G-R. Monteggia involves the ulna. Galeazzi involves the radius, Mugger. Now for the spelling, Monteggia, M ends with A. A being the first letter of the alphabet, you're thinking proximal, right? Galeazzi, Galeazzi, Z is the end. Z there is more at the end of the alphabet. So you're thinking of more distally. So again, to summarize, Monteggia, Mugger, MU, Monteggia ulnar, Monteggia MA, A being proximal, Monteggia ulna proximal. Galeazzi, Galeazzi Mugger, Galeazzi radius, Galeazzi Z, Galeazzi distal. So Galeazzi, radius, and distal. Okay? This illustration right here is very helpful. Next, what's the organ most susceptible to blunt trauma and is frequently involved in upper torso penetrating wounds? It is your liver. Why? Because the liver is the largest organ in the body. So if you hit somewhere in the abdomen, you have a high likelihood chance of hitting the liver because it takes up much space in your abdomen, right? What's the initial evaluations for patients with blunt abdominal trauma? Before, they were using DPL or diagnostic peritoneal lavage. However, it has been since supplanted, been replaced by a more accessible, more affordable, and easier to interpret and less invasive, fast or focused assessment sonography for trauma, right? So we actually have 4 areas of the abdomen to identify or to evaluate in FAST. We have the hepatorenal recess on the right, the peristaltic view in the left. Down, we have your suprapubic window, the Douglas pouch, and up, we have the subxiphoid pericardial window. Okay, we have the EFAST later on, The E fast is extended fast, which has the four, again, liver, spleen, dependent portion, pelvic area, subxiphoid, which now includes the E fast includes the hemithoraces to identify if there's if there's a hemothorax or a pneumoperitoneum or other injuries identified in the thoraces. Next, post-op after X-lap for a gunshot wound, patient was having decreased urine output, increased pulmonary inspiratory pressures, increased cardiac preload, and decreased cardiac output. What's the most likely diagnosis? So these set of parameters, a decreasing urine output, increasing inspiratory pressure, a decreasing cardiac preload, and decreasing cardiac output, are characteristic of what we call abdominal compartment syndrome. So what's the abdominal compartment syndrome? Abdominal compartment syndrome is when the abdomen is when the visceral organs in the abdomen is pushing against the other organs surrounding them, causing symptoms of cardiovascular collapse, right? For example, the bowels are edematous. They're gonna get bigger and bigger. They're gonna expand. As a result, some of those the pressure inside the abdomen is gonna push against your ureters. If they're pushing on the ureters, they're pushing on the renal vasculature. As a result, you're gonna have decreased urine output. Next, if the bowels get larger, it's gonna push up your diaphragm. As a result, if the diaphragm is pushed up enough, the inspiratory effort of the patient will not be enough. Next, if it's gonna push into the great vessels at the back, especially your vena cava, you're gonna get decreased cardiac preload. Blood is not gonna go back to the heart immediately because the bowels there, the pressure there is pressing up against the IVC, right? And decreasing cardiac output. This was the blood pressure of ACS requiring intervention. That's 35 millimeters mercury. Some references will say abdominal compartment syndrome begins to be evident at 20 millimeters mercury. However, this one is a previous board exam question. It just asked, when do we intervene? Even though ACS is diagnosed at somewhere around 20 millimeters mercury, we only need to intervene at 35 millimeters mercury, right? How do we intervene? We open up the abdomen. If the problem is the pressure, we release the pressure. Sometimes we open up the abdomen, we close it with something sterile, then we revisit that if the bowels have decreased in edema later on, we close it back again. So next, burn patients. 20-year-old male suffered second-degree burns at the 20% TBSA. Patient weighs 70 kgs. Calculate for hydration. So what do? We use the Parkland's formula. So for the Parkland's formula, we have a constant factor there. That's 4 multiplied by the total body percentage of burn. So this one already gave you 20%. That's 4 times 20 multiplied by the weight of the patient. So it's 4, which is again constant, 20, burn percent, 70 kilograms. So 4 times 20 times 70, you get 5.6 cc in 24 hours, right? How do you give it? We need to divide it into 8 and 16 hours. You divide it into 2, you give the first half in 8 hours, you give the second half in 16 hours, right? So first 8 hours, 2,000, you need to half your 5.6. So 5,600 divided by 2, that's 2,800. You divide it into 8 hours, that's 350 cc per hour for 8 hours. For the second half, the second 2,800, you need to divide it by 16 hours. You need to give it by 175 cc per hour for the next 16 hours. Okay? Now, there was a previous confusion because Schwartz has since updated their definition for a Parkland formula to the ABA formula, right? And also some references would say that the modified Parkland is different already. Again, Parkland is 4 times TBSA times weight. They say that the newer modified Parkland makes use of 2, right? But actually, in Schwartz, it specifies that the name of that formula using 2 is the ABA formula, right? The ABA formula. So personally for me, if I were asked the question, solve using Parkland's formula, I'm not gonna make use of the modified parklands unless the question specifies modified parklands. I'm not gonna make use of 2 because in Schwartz, that modified parklands is named as ABA formula. I'm still gonna make use of 4. Again, even though 2 is more recent, 2 times C base A times weight, I still believe in going word by word for the question, right? Because sometimes the examiners, they just try to confuse you. But you need to stick on what's on the question, because if it's in the question, you're not gonna get faulted for that, even if you get a mistake later on, right? Because it's in the question. So if the question is asking only for parklands, you don't answer modified parklands, you don't answer the ABA, still go by 4, right? You don't answer 2. Even though 2 is more recent and is more recently accepted, right? Resuscitation as above prevents the conversion of this zone to an even deeper wound. So we have 3 zones. We have coagulation, we have stasis, and we have hyperemia. Coagulation needs excision and grafting. Stasis is just around the coagulation, and hyperemia is the vasodilation surrounding it. So for coagulation, can't do anything about it, you just need to excise it. For hyperemia, it's just inflammation. But the one that you need to save is the zone of stasis. That's where your hydration, your resuscitation, your monitoring of the patient comes in, and wound care also comes in. So, for purposes of the board exam, they don't usually ask you to solve, but when they do, they give you specific parts of the body. For the burn percentages, they give you specific parts of the body, and you need to surmise it from those parameters in the question, right? So a good way I remember this is by this 9-man here. So what I do is I put 9 for the head. So 9 for the whole head, that's 4.5 in the front, 4.5 in the back. 9 for the whole 2 arms, so 4.5 back, 4.5 front, 4.5 back, 4.5 front, 4.5 back. Now, 4 9s for the body, because that's 2 9s in the front, 2 9s in the back. For the legs, that's 9 only for the thighs and 9 for the legs. For the thighs, 4.5 in the front, 4.5 in the back. For the legs, we have 4.5 in the back, 4.5 in the front, and 4.5 in the back. And you have 1 for the genital area, right? So you can try to draw this, and this has helped me. I don't know if you can memorize the whole image, but this has helped me a few times in burn solving. Right? Next, 8-year-old male subcutaneous swelling midline near the hyoid complains of recurrent infections of this mass after an upper respiratory tract infection. What's the procedure of choice? If it's a child with a midline mass, you're thinking more commonly of a thyroglossal duct cyst. And the surgery for a thyroglossal duct cyst is a cyst-to-lung procedure. So what's a thyroglossal duct cyst? Your thyroid moves from the base of the tongue down to its final position at its location in the thyroid cartilage, right? Okay. If it moves down there, it creates a plaque, and the plaque may become persistently patent even after it has reached its final endpoint. And that plaque may become infected later on, right? So this is your thyroglossal duct cyst. What we do the cyst-to-lung procedure. We remove the cyst, we remove the tract, and we remove the central portion of the hyoid bone, because usually the tract is adherent there. So this is different from a branchial cleft cyst because, again, branchial cleft cysts are more lateral. Thyroglossal duct cyst, the question will usually specify midline, moves with deglutition, okay? Or if we're thinking of a lateral mass, that's a branchial cleft cyst. So we generally have 3 types, first, second, third branchial cleft cyst. The first one travels from the preauricular area to the middle ear. The second one, both travels in the SCM. The second one goes to the tonsillar fossa. The third one goes to the piriform sinus, right? So 3 branchial cleft cysts, lateral, thyroglossal duct cyst, more midline, okay? Next, what's the most common salivary gland tumor? The most common salivary gland tumor is your pleomorphic adenoma or your benign mixed tumors. So you have the rule of 80s for salivary gland tumors. 80% are found in the parotid gland, 80% are benign, and 80% are made up of your pleomorphic adenoma. The second most common is actually your Warthin's tumor. Both your pleomorphic adenoma and your Warthin's tumor are actually more benign causes of salivary gland tumors. If we're talking about malignant causes, the most common of which is your mucoepidermoid carcinoma. A mucoepidermoid carcinoma. You have the 25, 50, 75 rule. So 25% of malignant tumors are found in the parotid gland, 50 are found in the submandibular gland, and 75% of those tumors found in the sublingual gland are malignant. So here's the table. I think this is in your handout also. Most common benign, pleomorphic adenoma. Second most common benign, that's Warthin's tumor. Most common malignant, that's mucoepidermoid carcinoma. Second most common malignant, we need to differentiate if it's adult or children. For adults, it's your adenoid cystic carcinoma. For children, it's your acinic cell carcinoma. Again, benign, first, pleomorphic, second, Warthin's. Malignant, first, mucoepidermoid, second, different if adult or child. Adult, you have your adenoid cystic carcinoma. For child, you have your acinic cell carcinoma. Next, 50, status post-parotidectomy for pleomorphic adenoma, noted swelling sweating at the right side for operation during feeding. What's the most likely diagnosis? So this is when the patient eats, they cry, sometimes it's called as crocodile tears. This is your Frey syndrome. So Frey syndrome is an aberrant reinnervation of postganglionic neurons, right? So you most likely have injured a certain nerve here, and after it has been injured, it reconnects sympathetically to the sweating cells there, right? So every time you eat, every time that nerve becomes stimulated, it also sends feedback to the sweat, causing you to sweat, and to the sweat glands, causing you to sweat every time you eat. That's your Frey syndrome. And the nerve involved in your Frey syndrome is the auriculotemporal nerve, which is actually a branch of the V3 of your trigeminal nerve. Right? Frey syndrome, auriculotemporal nerve. However, the question, most commonly injured nerve in parotidectomy, so that you just don't get confused, okay? Frey syndrome is classic. It has been asked in the board exams, but I think the board of examiners will try to confuse you by asking the most commonly injured nerve. Frey syndrome, auriculotemporal nerve, but it's not the most common. If parotidectomy, the most common nerve involved is your marginal mandibular branch of the facial nerve. Again, it's the marginal mandibular branch of the facial nerve. It's the most commonly injured nerve in parotidectomy. Next, 40-year-old female underwent FNAB for a solitary thyroid nodule. Biopsy revealed Samoma bodies and orphan Annie nuclei. What's the diagnosis? Okay, Samoma bodies and orphan Annie nuclei are characteristic of the most common type of thyroid neoplasm or papillary carcinoma. Again, it's the most common type of thyroid malignancy. So we're orphan Annie nuclei here with nuclear grooving, empty spaces between those, looking like your cartoon orphan Annie, right? Good mnemonic also for the Samoma bodies is you have your Samoma, PSM, P, papillary carcinoma of the thyroid or papillary carcinoma of the kidneys, S, serous adenoma, M, meningioma, right? Samoma, PSM. What's the most important prognostic factor for patients with thyroid CA? It's actually the age. Before it is 45. More recently, it has been 55. Why? Interestingly, if you have metastasis but you're less than 55 years old, you only get stage 2. But if you have metastasis and you're more than 55 years old, you're going to get stage 4. Right? So that's a peculiar thing about your thyroid malignancies. Next, type of neck dissection that removes level 1 to 5 lymphatics but preserves the spinal accessory nerve, the IJV, and the sternocleidomastoid muscle. We have your MRND, modified radical neck dissection. You have 3 types of your MRND. Depending on what structure you preserve, you have type 1, 2, and 3. If you preserve the S, the first one, the spinal accessory nerve, that's type 1. If we preserve the S and the I, that's spinal accessory nerve plus internal jugular vein, that's 2. If you preserve the spinal accessory nerve, the IJ, and the M, sternocleidomastoid muscle, you get type 3. So the name for that again is SIM 1S, spinal accessory nerve, 2, SI, spinal accessory nerve, internal jugular vein, 3, spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. Okay? If you have different types of dissection, I just included a diagram here for you to understand, for you to reminder, for you to identify, to familiarize yourself with the diagrams. right? Because sometimes the board examiners will try to differentiate posterolateral versus lateral versus anterolateral neck dissection. Next, patient with increased PTH, increased calcium, but decreased phosphate. What type of hyperparathyroidism? We have primary hyperparathyroidism. I know this will be discussed more in depth, I think, in ureteral medicine and your patho lectures. However, this has popped out in the surgery board exam. So for primary, increased PTH causes increased calcium. So examples would include your adenoma, hyperplasia, and your carcinoma. Most common of which is your adenoma, right? For secondary, the increase in PTH is only secondary to a decrease in calcium. Remember that PTH is increased if calcium is decreased because PTH will try to push calcium up, right? It's going to feed back. So the secondary hyperparathyroidism is due to a decreased calcium, such as in calcium-losing diseases such as your chronic renal failure and vitamin D deficiency. However, if that chronic renal failure, patients who are post-transplant, patients who have renal problems, chronically ongoing, which predisposes the patient to a tertiary type of hyperparathyroidism in which everything is increased. Okay? What's the classic pentad of symptoms? This also come out of the board exams. You have stones, bones, groans, moans, and overtones. Kidney stones, painful bones, abdominal groans, psychic moans, and fatigue overtones. Right? How to localize? We need to use a sesame B scan or 99 technetium scan. If it's only one gland, then that's most likely an adenoma. So what do? You just remove that gland. If there's more than one gland, there's usually hyperplasia. And what you do is you remove 3.5 parathyroidectomy or a total parathyroidectomy, then you autotransplant. What's autotransplant? You remove one, then you plant it where? Sometimes in the SCM, sternocleidomastoid muscle, sometimes in the forearm, right? For carcinoma, you do end block resection, then remove one part of the thyroid lobe. What's the most common location of a missed gland? So this might be confusing. Missed gland means that you missed it. If you missed it, it's probably where you left it. It's a normal anatomic location. However, if the question is asking for the most common location of an ectopic gland, ectopic means it's really not there. The most common location is the thymus, right? Missed gland, normal, ectopic gland, thymus. Next, nodes interpose between the pectoralis major and minor and receive lymph drainage directly from the breast. So between both pectoralis muscle, your interpectoral nodes or Rotter's nodes. Okay, so you actually have three levels of nodes in the axilla. You have level 1, 2, and 3. Level 1 is lateral. Level 2 is the one between your muscles. And level 3 is your mid-lateral. Right? So what muscle serves as the landmark for this one? The muscle that divides the axillary groups or your pectoralis is your pectoralis minor muscle. Okay? Next, also for the anatomy of the breast, which quadrant is usually associated with malignancy? Of course, the quadrant with the highest percentage of breast tissue, up to 75%. And this is the lateral, upper lateral quadrant, upper outer. Why? Because you have a tail of spence extending into the axilla there. It's where most of your breast tissue is found. Thus, it's the site of the most more common quadrant associated with carcinoma. Next, 40-year-old female underwent sonomammogram result BI-RADS 4. What's the next step in management? So for BI-RADS 4, this is actually suspicious for malignancy. What you do is you perform biopsy. So the BI-RADS scoring system is used to identify patients with breast imaging, whether ultrasound or mammogram, and correlate it into the risk of developing a malignancy so that you can form a management plan later on. Just so that it doesn't confuse you, Bethesda is thyroid, BI-RADS is breast. A way to remember this is Bethesda has a letter T, T is thyroid there. Okay? So I remember it because personally I get confused sometimes. Both are letter B, Bethesda, BI-RADS, which is which? BI-RADS is for breast, Bethesda is for thyroid because of the letter T there. Bethesda is actually FNAB result. Your BI-RADS is imaging result. Right? So here we have 6 levels, but we actually have 7 categories because you include 0 there. 0, bar 0 is incomplete, so you repeat the imaging. 1 and 2, 1 is normal, 2 is benign. So what do? you do a routine screening on the patient. Okay? 3 is benign, probably benign. 4 is probably malignant. 5 is highly suggestive malignancy, and 6 is biopsy-proven malignancy. Okay? So again, 1 and 2, routine screening. 3, you do short interval follow-up. So instead of annual, you do it abbreviated into 6 months. Okay? For 4, it's probably malignant. You get 4A, 4B, and 4C, low, intermediate, moderate. Basta for all those, you do biopsy. So ideally, for the breast, or first-line biopsy technique is your corneal biopsy. Or sometimes FNAB might be acceptable, but the FNAB will not guarantee you identifying carcinoma, because if it's low yield, also, you won't identify if it's invasive or not. You just know that there's cancer there using the FNAB. Because again, the FNAB has a smaller needle. It only gets the cells. Your core needle gets the architecture. Because it's larger. It can put more tissue inside your specimen, right? 5, highly suggestive malignancy, appropriate actions. You do biopsy, prepare the patient for surgery. And 6, that's already biopsy proven. So you proceed with your next workup or with your next management. Either chemo or neoadjuvant, or you need to do per surgery. Okay, take nodes. Right? I've summarized the number of nodes needed for certain surgical procedures or oncologic resections. For breast cancer, it's 10 to 15. Again, 10 to 15. Take nodes. Minimum number of nodes in gastric cancer, it's 16. And gastric cancer, 16. Colonic cancer, it's 12. Gallbladder cancer, it's 6. Breast cancer, it's 10 to 15. Gastric cancer, it's 16. Colonic cancer, it's 12. Gallbladder cancer, it's 6. Okay? Next, SERM, a selective estrogen receptor modulator, first shown to reduce the incidence of breast cancer in women. So, remember, if we're taking a biopsy sample of a breast patient, we also need to identify its hormonal status. We get the ER, estrogen receptor, progesterone receptor, and the HER2 new. Okay? The ER-PR there is for you to decide what best treatment to give to the patient. If this patient can be given a certain type of treatment, this treatment is hormonally mediated because these are estrogen and progesterone receptors. So you have the SERM. We use tamoxifen as adjuvant hormonal therapy or as chemo prevention. So tamoxifen targets the estrogen and prevents breast tissue from proliferating. That's your tamoxifen. Side effects, endometrial cancer, thromboembolic events, cataract, and vasomotor disturbances. Molecular subtypes responsive to tamoxifen, we have 2. This is popped out in the board exam. We have luminal A and luminal B. A and B both are ER positive. The difference is that in luminal B, you will have a positive HER2 new. Luminal A is only positive ER, with or without PR. B is ER, with or without PR, with HER2. HER2 is only HER2 enriched, triple negative, worst prognosis, negative everything. Okay? Again, worst prognosis is a triple negative breast cancer. Next, more effective in reducing the incidence of contralateral breast cancer in postmenopausal women. So, in premenopausal, we give SERMs, we give tamoxifen. In postmenopausal women, we give aromatase inhibitors. A good example would be your anastrozole. Okay, tamoxifen for premenopausal is not actually also suggested to be given to postmenopausal women because tamoxifen increases the chance of cardioembolic events. Okay, next, melanoma screening. What does D stand for? D stands for diameter. We have asymmetry, border, color, diameter, and involving. The diameter there is more than 6 millimeters. What's the most common subtype of melanoma? Superficial spreading. Okay, so different types: superficial spreading, nodular, lentigomaligna, and acral lentiginous. This is in your handouts. Just want to remind you, most common subtype, we have your superficial spreading. We next should memorize all the Clark levels, but I'll leave that to you on your handouts. Sorry, I'm trying to include everything in the short amount of time that I have. So I'm still pacing myself, but sorry if I get too fast in a bit. Okay. 30-year-old female, developed tender deep nodules at axilla and inframammary fold. What's the most likely diagnosis? So I know sometimes the board examiners have fetishes for different dermatologic conditions because I think one of the board examiners before was derma. This has popped out in patho, IM, and also in surgery. So this is your hydradenitis suppurativa. So usually you treat this medically at first. If it's persistent, you then need to excise the apocrine glands that are chronically inflamed. So multiple tender nodules is hydradenitis suppurativa. Next, abdominal wall hernia found in the junction of the semilunaris and the arcuate line. So in between the semilunaris and the arcuate line, you have your spigelian hernia. So it's more lateral, no, as compared to the epigastric and umbilical hernia, which are more midline. What's the hernia of the back? So we have two. We have the superior lumbal triangle hernia, the Greenfeld shaft, and the inferior triangle hernia, the petit. A good way to remember this is Greenfeld, shaft, superior. Greenfeld sounds like Gryffindor, and Gryffindor is superior. So Greenfeld shaft, superior triangle. Petit means small, petit means inferior, so inferior triangle, right? Next, type of hernia with strangulation but without obstruction. So if a hernia gets strangulated, you're gonna think, if it's strangulated, no bowel is gonna come out, right? But there's one type of hernia in which even if it's strangulated, some of the bowel contents can still pass through, so it's not obstructed. So this is your Richter's hernia. Richter's hernia, because in Richter's hernia, only one side of the bowel is strangulated. The other side is still open. Bowel contents can still pass through. That's Richter's hernia. Okay, so we have some names, eponyms of hernias here that I'd like to give mnemonics to so that you can easily remember them. For Richter's hernia, Richter, I remember this as recta. Why? Richter hernia, you can have strangulation but it's not obstruction. So recta pa rin yung bowel contents. So recta, Richter's hernia. Next, litter hernia, litter for little, because in little patients, we have your Meckel's diverticulum, right? For pantaloon hernia, parang pantalon, so you have two legs, you have two legs of the trousers, so you have a direct and an indirect hernia. In between is your inguinal, inferior epigastric vessel, right? For Madel's hernia, there's two bowels in the sac Madel's. So we remember this is Madel's, may dalawa, Madel's hernia. And we have the Amian's hernia, which is herniation of the appendix. So Amian, letter A, Amiandix. Okay. Next, what are the borders of the triangle of Hasselbalch? Medially, we have your rectus abdominis muscle. Superolaterally, we have your inferior epigastric vessels. Inferiolaterally, we have your inguinal ligament, right? So if it's medial to the inferior epigastric vessel, we have your inferior epigastric vessel here. If it's within the Hasselbalch triangle, it is a direct hernia. Direct because this is a triangle, right? You have the inguinal canal right here, right? If it passes to the Hasselbalch triangle, it's directly on the inguinal canal immediately. However, if it's outside the Hasselbalch triangle, it needs to pass first to the internal ring. So that's your indirect hernia, because indirect, it's not directly going into the sac. It's gonna pass through the internal ring first, then the canal, right? Or sometimes there's a question in our board exam which asked laparoscopically what marker can be used to identify if it's a direct or indirect hernia. You have the lateral umbilical fold. Okay. Next, for the NIHOS classification, we have 4 types. Type 1 is where you have a normal internal abdominal ring. Type 2 is where the ring is enlarged but does not extend to the scrotum. Type 3 is where you have indirect sliding straddle and pantaloon hernias, and type 4 is your recurrent hernias. Okay. For type 1, ring normal. Type 2, ring enlarged. Type 3 is when the hernia sac and the bowel contents and everything goes in. Okay, that's already type 3. Specifically, it's type 3B because type 3A is a direct hernia, type 3C is a femoral hernia, and type 4 is already recurrent. Again, NIHOS 1, normal ring. NIHOS 2, large ring, but no bowel contents inside. NIHOS 3B, extends inside, goes to the scrotum. That's 3B. 3A is direct. 3C is femoral, and 4 is recurrent. But more recently, we have been using the European Hernia Society classification. The NICE classification is old, but it's still being asked in the board exam. So it's very helpful for you to memorize it. Basta normal, enlarged, umabot sa scrotum, that's 1, 2, and 3B. 3A is direct, 3C is femoral, and 4 is recurrent. Next, congenital hernias naman. Newborn noted visible bowel and viscera covered with a complete sac and is found in the midline. Covered with a sac in the midline, that is your omphalocele. A good way to remember this is O. O looks like a sac. O looks like it's in the middle. Now, you need to differentiate an omphalocele versus gastroschisis, right? For an omphalocele, it's in the midline, it's in the umbilicus. For gastroschisis, it's in the right. Gastroschisis, gastrite. So you remember it. For fascial defect, it's variable. For gastroschisis, usually less than 4. The sac is present in the omphalocele and is absent in the gastroschisis. Okay? For omphalocele and gastroschisis, we need to identify which is which because there is a prognosis that is different for each type of defect. So which of the two is more severe or more worse? That is your omphalocele. Why? Because the omphalocele, as seen is stable right here, is actually associated with other anomalies such as your cloacal extrophy, Beckwith-Wiedemann, and your Candida's pathology. Where gastroschisis, although it might look very bad because you can see bowels are going out, but take note that those bowels outside are already leathery and shortened. They have adapted to the amniotic sac. They have adapted being outside the abdomen. So it's actually very tough. When you put them inside, the patients usually go back to normal as compared to omphalocele, which usually have other defects. Most common of which are your cardiac anomalies. Okay. 20-year-old male presents with abdominal mass. Physical exam reveals that the mass only moves laterally. What's the diagnosis? So 20-year-old male, abdominal mass inside. The mass can go left and right only. This is your Tilau sign, which is identifier of your mesenteric cyst. As compared to a mass that goes in all directions, your omental cyst, omental, all directions, we can easily visualize them by thinking mesentery, remember, is at the back. It holds your bowels to the retroperitoneum. Your omentum is in the front. It's just there. It's just lying around, right? So in the mesentery, if you have a cyst there, remember, it's stuck to the peritoneum. It can only move to one side or one direction. Up, left, right, right? If it's in the front, if it's in the omentum, it can go anywhere it wants. So Tilau sign, mesenteric, omental, all directions. For abdominal wall masses, also, we have an anterior abdominal wall mass that do not cross midline and is still palpable when the muscles are tense. We have the Fothergill sign or the rectus sheath hematoma. So the Fothergill sign, you palpate the mass, you ask the patient to sit up. If the mass is still there, it means that the mass is in the abdominal wall. Right? Most likely in the rectus sheath, most probably from a hematoma. Right? However, if the mass disappears, it means that the muscles has contracted and prevented the mass from being palpable. So it's usually it means that the mass is at the back. So it's a negative Fothergill sign. It's not rectus sheath hematoma. But if it's persistent, if it's there, that's a rectus sheath hematoma and a Fothergill sign, right? Next, patient presents with dysphagia. Dysphagia manometry done revealing incomplete relaxation of the LES. Hypertonic with aperistalsis. What's the diagnosis? So this is characteristic of your achalasia. Achalasia is very classic. It's very historical. It's very significant. It sounds very okay. It sounds very nice. However, achalasia is not the most common. I'll show you what's the most common later on. So what's the imaging modalities? We can use of X-rays. We can use of upper GI series, where we identify the bird's beak sign. The bird's beak sign is where you have a beak at the point where the muscles of the esophagus are so tense, it's not allowing any contrast to pass through. So that's your achalasia. What's the treatment? If the problem is the muscles, what do? You relax those muscles by doing incisions. You can do laparoscopically, you can do it open. We have the Heller's myotomy. Heller myotomy. Myotomy, muscle-tomy, splitting, muscle splitting. You split the muscles to allow it to relax. Now we have different motility disorders, and sometimes they have questions which describe a particular manometric reading, and you need to identify which is which, right? Right. So I'm going to simplify it for you. So we can differentiate them first into high or normal LES pressures. We have achalasia or hypertensive LES. both of them have high LES pressure. So let's group them together. Next, for normal LES pressure, we have your diffuse esophageal spasm and nutcrackers. LES, by the way, is lower esophageal sphincter, the one just before the stomach, right? If it's high, it's either achalasia or hypertensive LES. Okay. The way I remember this is that in hypertensive LES, the LES is hypertensive, but it's just that. The peristalsis there is normal because it's just hypertensive LES, right? However, if there's peristaltic dysfunction, if there's absence of peristalsis, then that's already achalasia, right? Tense LES, it's either hypertensive LES or achalasia. If it's just a tense LES, it's hypertensive LES. If there's absence of peristalsis, it's also achalasia, right? Next, if the LES pressure is normal, okay, you can either think of DES or nutcracker's esophagus. So what is DES? Diffuse esophageal spasm. So remember, you have your esophagus right here, right? Esophagus right here. If the peristalsis is high amplitude, but it's not coordinated, it's going here, 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 here. It's not going to one direction, and that's diffuse esophageal neoplasm, right? Sometimes identified as a corkscrew esophagus. For the nutcracker's esophagus, it's coordinated. It's going up to down, mimicking a normal peristalsis. But the problem is that it's very, very, very strong. And it's a nutcracker esophagus, right? The most common severe motility disorder, it's your nutcracker's esophagus. Again, achalasia is just classic. It's just historical. It's high yield. However, the most common still is your nutcracker's esophagus. Okay, so easy way to remember your motility disorders of the esophagus. Next, infant presents with excessive drooling, inability to pass an orgasmic tube into the stomach. What's the diagnosis? The diagnosis is your tracheoesophageal fistula, right? If you can't pass an OGT, there's probably an atresia there in the esophagus. It's usually associated with a fistula, right? So we have actually 6 types. You have your A, B, C, D, E, F. However, the more important ones are your A and your C. The most common type of TEF is your type C. Your type C is atresia with distal tracheoesophageal fistula, right? The second most common is your type A. Okay, esophageal atresia without tracheoesophageal fistula. Okay, sorry, I'm running out of time, but allow me to extend for a bit. A is just atresia without a fistula. So the esophagus is just problematic there. The trachea is okay. Next, atresia, but on top, there's a connection to the trachea. That's atresia with proximal compared to your type C with atresia, but the distal end is connected to the trachea. Type D is a double fistula. Type E is fistula with atresia, and type F is stenosis. But then, what's the diagnostic sign? You try to insert an OGT, and if it can't pass, yes, doc, sorry.
Doc, your camera is off.
Ay, sorry.
Thank-
Can you see me now, doc?
Yes, Doc.
Okay, thank you. So, if the OGT passes into the stomach, okay, if the OGT passes into the stomach, it's not atresia. But if it coils up and you see it on an X-ray, and the patient is drooling with a classic pathognomonic signs, you're thinking of esophageal atresia. However, among the 6 types of TF, there's one that does not present as an inability to pass the OGT. Right? Which of the 6 does not present as inability to pass an OGT? The one that does not have an atresia. That's your type A. TF without atresia. Okay? X-ray, just so that I can emphasize to you, you can see both X-rays have an OGT that does not reach the stomach. So both must have an atresia. However, we need to identify if this is a type A or type C, the 2 being the most common, C being the most common, and A being the second most common. Type A usually has a gasless stomach. Why? Because there's no fistula. If there's no fistula, the stomach will always be collapsed because there's no air going to the stomach. But if there's a fistula, it's most likely type C. Esophageal atresia with distal tracheoesophageal fistula. Right? Next, what's the most common type of esophageal cancer worldwide? So the most common type of esophageal cancer worldwide is your squamous cell carcinoma. What's the most common type in the middle third of the esophagus? Still your squamous cell carcinoma. A good way to remember this is squamous, second portion, smoker. Squamous, second portion, and smoker. It's in the middle, squamous and smoker, letter S. Okay. For the distal third of the esophagus, we have your adenocarcinoma, and it's actually more common in developed countries, right? But worldwide, still squamous carcinoma. So a good way to remember this is adenocarcinoma and acid. Distal is where your acid reflux goes in, right? So distal third, adenocarcinoma, and your acid. What's the most important etiologic factor in the development of primary adenocarcinoma of the esophagus? So for adenocarcinoma, it has a precursor lesion, which we call as your Barrett esophagus. Okay, this is transition from the normal squamous epithelium to the columnar type. Columnar being more resistant to acid. You only expect to see columnar in the intestines. However, if you see it in the esophagus, it means that the esophagus is trying hard to prevent acid from hurting the esophageal structures, right? So it's transitioning from squamous to columnar. So that's your Barrett's esophagus. Next, we go to the hiatal hernias. The most common type of hiatal hernia, we have your type 1 sliding hernia. Type 1 being the most common type, and it's also the one that is treated medically, or type 1 sliding hernia. So type 1, you have a hernia defect here. It's sliding, it just goes up and down, up and down. The GE junction, the cardia goes up and down. For type 2 rolling, if you have a defect here, you have the esophagus here, one part of the stomach, particularly your fundus, remember the fundus is the cap of the stomach, the head of the stomach, goes at the side. So it's rolling at the side, right? It's for the sliding, which goes up and down, rolling goes in the side. Type 3 is combined 1 and 2, and type 4 is an additional organ. So it's usually colon or other organs, aside from the stomach. Okay? Next, type of ulcer with increased acid output. We have Johnson classifications 1 to 5. The ones associated with increased acid output, as asked in the previous board exam, is your type 2 and 3. So for Johnson's classification, we have 1, 2, 3, 4, and 5. 1 is less, 2 is 2, 3 is pre, 4 is door, 5 is NSAID with 5 letters. That's the mnemonic for it. 1, 1 less. Less, lesser curvature. 2, 2. 2 ulcers, gastric and duodenal. 3 is pre. Pre-pyloric means just before it ends the pylorus, there you have a ulcer there. 4 is door, opening into the stomach. If you have the stomach here, if your GE junction here, the door is right here, right? So if the peptic ulcer is there, that's type 4. And 5, NSAID, because NSAID has 5 letters, okay? So 1 less, 2, 2, pre, 4, door, 5 is NSAID. Types of ulcer with decreased mucosal protection, you have type 1 and type 4, because type 5 is NSAID induced. Most common complication of peptic ulcer disease is your bleeding. The second most common complication is your perforation. Okay. Eventually, you have your obstruction and we have your malignancy, but those are less common complications. The most common is still bleeding. Upright chest radiographs shows pneumoperitoneum in which percent of cases? It's only accurate in 80% of cases. So you can have a patient who has a perforated stomach but will not present with pneumoperitoneum in 20% of cases. 1 patient out of 5. Okay. Next, we go to the liver. Upper border of the triangle of Callot, we have the cystic artery. Structure in the center of the triangle of Callot, we have your Callot's node. Now, the confusion lies in that Schwartz actually got confused himself, right? Because in Schwartz, he states that the hepatocystic triangle is actually the same as the triangle of Callot. But if we base it off anatomy books, they actually specified that the triangle of Callot is different from the hepatocystic triangle. As shown in this illustration right here, get out my pen, the yellow one is the Callot triangle. The Callot triangle is included in the larger hepatocystic triangle, right? In the center of the triangle of Callot, you have the Callot's node. In the center of your hepatocystic triangle, you have the cystic artery. Okay, the upper border of the triangle of Callot, we have your cystic artery right here. Let me erase so that you can see the diagrams again, right? Okay. So you can see that the upper border of the triangle of Callot is still your cystic artery. However, for the hepatocystic triangle, the upper border is the liver. The rest of the borders are the same for both Callot and hepatocystic triangle. The medial border is the common hepatic duct. The lateral border is the cystic duct. Okay? The difference is the superior border. Calo, cystic artery, hepatocystic, hepatocystic. Hepato gives you idea that it reaches up to the liver. Okay? In Calo triangle, you're trying to find the Calo node. In the hepatocystic triangle, trying to find the cystic artery. Right? Okay. Gunshot wound to the liver, Pringle maneuver applied, liver bleeding unchanged. What's the injury? So if there's a gunshot wound to the liver, we're going to think an injury to the portal veins, hepatic veins, and the hepatic arteries. So we're going to stop the source of bleeding by stopping the vessels that feed the liver. So you can clamp the hepatoduodenal ligament and stop the bleeding of the liver. However, if the bleeding persists, what does it say? It means the bleeding comes at the back of the liver, retrohepatically by the inferior vena cava and the retrohepatic veins, right? Okay, so Pringle maneuver, if it stops bleeding, okay. If it does not stop bleeding, this is a board exam question, the bleeding usually comes from the back, the inferior vena cava, or the retrohepatic veins. Okay. Next, patient underwent cholecystectomy for gallstones. Biopsy revealed GBCA, gallbladder carcinoma. Histopath reveals a tumor to invade lamina propria. The next surgical plan, so what do? So you do a cholecystectomy, it turns out malignancy, but it's only up until the lamina propria. What do? Do you do hepatectomy? Do you do oncologic resection? You do nothing. Because for tumors to the gallbladder that only extends up to the lamina propria, I don't need to do anything. Cholecystectomy is enough. This is T1A lamina propria. No matter how busy this table gets, I just want you to understand lamina propria, T1A, gallbladder cancer, cholecystectomy alone enough. You just need to reassure the patient, and you can do monitoring or whatnot, but you don't need to do anything else. But for type 1B onward, you need to do more oncologic resection. You need to remove part of the liver. You need to remove some ligaments. Basta, just remember T1A, lamina propria, GBCA, cholecystectomy, just okay. Bile duct carcinoma. So GBCA is different from bile duct carcinoma. Bile duct carcinoma is otherwise known as your cholangiocarcinoma. And we have a special type of cholangiocarcinoma, actually it's a common type, found in the hilum, between where your common hepatic duct bifurcates to the right and the left hepatic, you have your Klatskin's tumor. So Klatskin's tumor is again cholangiocarcinoma of the bifurcation or the hilum of the biliary ducts. So how do we how do we classify them? By the bismuth correlate classification, and I think it's in your handouts. Next, choledochal cyst with fusiform dilation of the extrahepatic biliary tree. So we have your type 1 choledochal cyst. So it's actually the most common type. Okay, and the way I remember this is I remember this table right here. Type 1 is first is F is fusiform. So what do you do with F? You remove the type 1 and you connect the intrahepatics to the jejunum. So that's excision plus Roux-en-Y hepatico-J. For 2 is second is S is saccular. So saccular diverticulum, you have a sac there. That's type 2. You just excise and put a T-tube in there. Type 3 is type 3. When I look at the number 3, I think of a sphincter, right? I think of an ampulla, right? So the type 3 is a choledococele and it's usually resolved by sphincterotomy. Okay? Type 4A, that's extra and intra. Type 4B, that's extra. Type 5, that's intrahepatic duct only, right? So what's the pathognomonic sign? The pathognomonic sign is a long common BP channel, biliary pancreatic channel. So remember, you have your biliary channel, you have your pancreatic channel, both of which drain to the common bile duct going to the duodenum, right? So pancreatic fluid, bile fluid. If it's very long here, what happens is that the pancreatic fluid is going to activate the bile fluid. If it activates the bile fluid, it's going to irritate the common bile duct. If it gets irritated, it's going to get bigger and bigger and bigger. If it's bigger, it becomes a choledococele, which is a saccular outpouching or a fusiform outpouching of your CBD, right? So what's the risk? So if you see choledococele, would you leave it alone? No, because the large size of that choledococcyl, along with the continuous inflammation and irritation, will predispose the patient to having cholangiocarcinoma. And this is a very high yield question in the board exams. Choledococcyls need to be resected because you don't want to risk malignancy later on, specifically your cholangiocarcinoma. Next, for liver abscesses, pyogenic abscess, that's Escherichia coli, treatment is antibiotics for 8 weeks. Okay, so when you aspirate, you see purulent material, then most likely it's pyogenic abscess, but you can do cultures on it. However, parasitic liver abscess, you usually have a case, travel to an endemic area, Mexico, Philippines, poor sanitation, limited access to clean water. You're thinking of amoebic abscess. E. histolytica, your entamoeba histolytica. If you get a fluid, you're gonna get your characteristic anchovy sauce. What do? You just give metronidazole for 7 to 10 days. Okay. Next, you see an abscess with double wall on CT. You think it's a hydatid cyst. Okay, in patients with sheep and in places with sheep and dogs, and endemic for hydatid cyst. Started on albendazole. What's the best time to perform an aspiration? So you see a cyst, it's hydatid. You think it's endemic. It's there's parasites there. When do you do aspiration? Again, just a trick question. Sorry, my camera keeps getting off. Doc, you can cut me off. I think I'm having technical issues with my camera. So, best time to perform an aspiration, you perform aspiration, never. Okay, you don't aspirate. Okay, it's usually your E. granulosus. Okay, why? If you aspirate it, it's gonna become the allergen is gonna spread out, and it's become the patient can become anaphylactic. Okay, a little bit more, just 5 slides more. I know, sorry. 6 slides more. What's the most common liver tumor? This is your hemangioma. If hemangioma with a consumptive coagulopathy, if it's very large enough and it's consuming your blood coagulation factors, it's called your Kasabach-Merritt syndrome. Hemangioma, what do you do? If patient is symptomatic, even if though it reaches very large sizes, we don't need to do anything. Basta provided the patient is symptomatic. What's the second most common liver tumor? That's your focal nodular hyperplasia, which is characterized by a central stellate scar. A scar. Focal nodular hyperplasia, stellate scar. Next, 40-year-old female taking OCPs without of a liver tumor. What's the most likely etiology? OCPs, think of adenomas. Basta female OCPs, adenomas. So adenomas, are they benign or malignant? They're benign. However, the problem is that, especially in females who are taking OCPs or who are pregnant with excess of estrogen, the adenomas are going to get big, 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 big. Eventually, they're going to lose blood supply. They're going to become necrotic and ischemic, and they're going to rupture into the abdomen. So for adenomas more than 4 to 5 cm, you usually excise them. Right? But the first line of treatment, for asked adenoma, taking pills, pregnant, what do? You stop taking pills, or you don't terminate the pregnancy, right? But usually it's associated with pregnancy. So you should observe after pregnancy. You try to manage it conservatively as best as you can. Next, history of multiple episodes of pancreatitis with hematemesis. Diagnosis, you have a splenic vein thrombosis. The splenic vein is thrombosed. The stomach is gonna get, the vessels in the stomach are gonna get, they're gonna dilate. So we're gonna have varices from it, right? So treatment, we do splenectomy, right? The most common indication for splenectomy overall is still trauma. However, hematologic disorders, carcinomas, among others, are also indications for splenectomy. However, the most common is trauma. What's the most common complication? It's infection. The most feared complication, it's OPSI, overwhelming post-splenectomy infection. Okay? So OPSI is very feared because it can predispose a patient to severe sepsis, which cannot be reversed. In order to prevent it, you only need to do vaccination. So vaccination, when? 2 weeks before, if elective, 2 weeks after, if stat or emergent. If elective, you need to prime the body that you're going to lose the spleen. So you need to produce as much antibodies as you can. If stat, you need to wait after 2 weeks because after you remove the spleen, the body is going to be in immunocompromised state. It is not going to be able to process those antigens from the vaccine immediately. So you need to wait until 2 weeks after. So you have 3 organisms, the 3 of which are capsulated because the spleen supposedly takes care of the capsulated organisms. So if the spleen is not there, the 3 of these you need to vaccinate against. S. pneumoniae, H. influenzae type B, and N meningitis. Plus, you can do annual influenza vaccination also. Again, S. pneumoniae, H. influenzae, and meningitis. Next, what's the most common anomaly of the GI tract? You have your Meckel's diverticulum, in which you have your rule of twos. 2% of the population, 2:1 male, 2 feet, 1/2 under 2 years old. 2 types of mucosa, gastric and pancreatic, in 2 inches in length. Now, I just want to emphasize the parameters here are all in not in metric system. So it's 2 feet, not meters, 2 inches, not cm. Because usually they confuse you with that. Feet, not meters, inches, not centimeters. Right? So is Meckel's diverticulum true or false? Diverticulum, it's true. What's the most common presentation in children? It's bleeding because you have heterotopic mucosa there. It's supposedly intestine, but if you have mucosa there that are gastric tissue or pancreatic tissue, it's going to produce acid, it's going to produce pancreatic juice, it's going to irritate the mucosa, causing bleeding. Right? In adults, however, they're past that bleeding stage, and eventually what happens is that they're going to hypertrophy, they're going to get, the cells are going to get, the tissues are going to get larger and larger until you obstruct. Okay, children bleeding, adults obstruction. Next, 3-year-old male with bilious vomiting with current jelly stools. This is intussusception. What's the most common cause of intussusception in children? It's lymphoid hyperplasia, okay, usually from upper respiratory tract infection. In adults, usually malignancy, right? Children, hyperplasia. In adults, it's malignancy. I just want you to memorize also intussusceptum versus sapiens. Septum is proximal, sapiens is distal. Sapiens is the recipient. Proximal, distal is gonna go in, right? Okay. Septum, again, septum, sapiens, recipient, sapiens, distal, it's the proximal, right? 25-year-old male presents with right lower quadrant pain. Surgeon makes patient's lie on his left side and extends the patient's right thigh if pain is elicited. This is a positive. So extension of the thigh. This is the psoas sign. This indicates a retrocecal appendix. If you rotate it, obturator, rotate sounds like, this is the obturator sign and indicates a pelvic appendix. Iliopsoas, retrocecal because the psoas muscle is at the back and you try to extend and stretch the muscle. What's the most common cause of appendicitis in adults? They are fecalitis. For Alvarado score, we have 2 points for RLQ tenderness and leukocytosis, diba? We have the Alvarado score, Mantrels, migration, anorexia, nausea, tenderness, rebound, and leukocytosis. So, last 2 slides more. Patients brought to the OR, no evidence of appendicitis found. Next step, you explore. If wala appendicitis, you explore. If wala pa rin appendicitis, you remove the appendix. Okay? Most common site of perforation is the cecum. Segment most vulnerable to obstruction is the sigmoid colon. And the most mobile part of the large intestine is the sigmoid colon. So we have the 369 rule there. It's in your handout. Just remember, cecum, largest, thinnest, it's prone to perforation. Sigmoid, narrowest, longest, most mobile, is prone to obstruction and also diverticulosis. Here we have a bent inner tube sign in a patient who is elderly with constipation. This is volvulus. But volvulus means it twists upon itself. So usually it's the sigmoid because the sigmoid is very mobile. The initial management is by imaging and endoscopy. You do detorsion. You push the scope there and you try to detort it. However, if not detorted, you can do surgery. If elective, you can do open sigmoid colectomy and anastomosis. If unsuccessful, you just divert. Last 2. Fistula and ano with no opening 2 cm anteriorly was anatomic course. So if it's anterior, we have the Goodsell's rule here. If it's anterior is actually downward there. It's a straight line. If it's posterior, it curves. We have a dog here to illustrate that. If it's anterior, it's straight. If it's posterior, it's curved. Except if it extends more than 3 cm, the anterior portion is gonna curve to the back, the posterior midline. What's the most common type? It's the intersphincteric fistula and ano, and the treatment goal is eradication of sepsis with these treatment modalities. Next, we have, sorry, just gonna go fast here. Dear Ian, a newborn patient, squirt sign is Hirschsprung disease. Dilated or normal segment, if it's dilated, it's actually normal. The contracted part or the normal part is actually the defective one because that contracted part is supposedly should be dilating, but because you have no ganglions there, it's still contracting. So a ganglionic is the normal, dilated is the Dilated is the normal, contracted is the abnormal. Diagnostic test, the rectal suction biopsy. You get there, you get sample there, you try to check for ganglion cells. You have the Swenson, swab, and Duhamel. So main nutrient of small bowel enterocytes, you have glutamine, amino acid A there, A, small, first letter of the alphabet, you think first part, small bowel, glutamine, amino acid. For colonocytes, more distally, you have your fatty acids now, butyrate, your fatty acids. Sorry, I have to squeeze in so much time, and so sorry I extended too much. But I hope you guys have learned a lot. Just a little thing I have to say before I end. I'm sure I'll be meeting you on Pearl's lecture, but at this point, you need to believe in yourself. Guys, at this point, I may be of no significance to you. You may not know me, but I still believe that you guys can do it. So if nobody like me can believe in you, then I guess you can believe in yourselves. So that ends tonight's lecture. Sorry for extending and for going fast in last part. Thank you.
Thank you, Dr. Pat. But before that, Dr. Pat,
Yes, Doc. Sorry.
sorry, yung cam na lang ang problem. Doc Pat, there are just some clarifications regarding sa parathyroid gland. Which is the most common for the ectopic parathyroids?
Doc, sorry. Is my camera visible?
No, Doc.
Sorry, technical problem talaga. For the ectopic, is usually found in the thymus, in the mediastinum. Ectopic parathyroids.
How about with the paraesophageal area?
One of the possible locations, pero according to literature, it's the thymus. If the student has a reference that might show paraesophageal, then they could send to me also. Pero according to my readings, it's the thymus.
Okay, Doc. Another question. Doc, regarding your presentation on adhesion lysis of the colon, why is it not class 2? We're under siya sa colorectal surgery. Dapat ba class 2?
It's not colorectal surgery per se because you don't enter the colon or the rectum. You just remove the adhesions. The adhesions are the ones sticking on top of it. You're not going inside the bowel, you're just removing the adhesions on top.
Okay, Doc. For the next question, how about yung topic on atresia, Doc? Yung presentation kanina of the case, should it be considering the case, should it be atresia?
Sorry, for which?
Yes. Atresia and echinacea.
I forgot which part, Doc. Sorry, which part of atresia?
I will clarify that. So, next. Dr. Swan, ano po ulit yung area for needle decompression? With regards
yes.
to the location of the rib and...
Historically, previous reference, they say it's the second intercostal space, mid-sternal line. But newer references, Schwartz 11th edition would say it's the anterior axillary line, 4th to 5th ICS.
Okay, will it be the same with the tube thoracostomy?
The tube thoracostomy is mid-axillary line, not anterior.
Okay. About, Doc, the most common liver abscess. What is the most common liver abscess?
Well, that's tricky because references would say it's pyogenic abscess, but if contextually, when we're talking about the Philippines, based on some readings I've seen, it's amoebic abscess.
So which one should
previously asked, Pat, for Dr. Antonio din kasi. So, tama ka, references will vary whether it's a pyogenic or amoebic liver abscess. But for Doc Lude, still overall though, amoebic liver abscess. So we will follow that.
Okay.
So, yes, good.
Okay. No more questions here. Thank you, Dr. Pat.
Thank you. Sorry for extending.
Okay lang, Doc.
No problem. Sulit naman, Dr. Pat, yung yung discussion. Okay, guys, ganito ang gimmick pagdating sa Sundays sa mga summary lectures natin. Personal recommendation, you don't need to write down notes. You don't need to furiously shuffle through your handouts kapag nagbibigay ng summary lecture. Makinig lang kayo. Talagang dapat, kaya siya ginawang 1 hour, 1.5 hours. Talagang parang minamasahe yung utak mo, para siyang dessert dun sa kinain mo. Okay? I would recommend that you actually watch it with other top-notch students at the same time. That's how you bond over coffee, inom ng konti kapag nagbibigay tayo ng summary lecture. At makinig lang kayo. Manood kayo sa TV, okay, for example, and just watch. Okay? There's no need really to write down notes kasi most of this naman is in your handout or pang-complement lang talaga dun sa main handout. Okay? Let's have a 2-minute break, Kimi. I want you
Yes,
to get your main handout for surgery after 2 minutes. I'll give the corrections and clarifications later. Okay, and also discuss, okay, it's causing some anxiety to our students, yung table of specifications ng boards. The test blueprint. Kung makalat-kalat kasi, akala nyo secret yan. Mamaya, after 2 minutes, I'll discuss. Thank you.
Yes, Doc. Thank you po.
Okay, let's resume. We gotten word from some of our teachers and mentors that may kumakalat na document called the Table of Specifications for the board exams. Okay? Guys, huwag kayong matakot okay? Yung Table of Specifications or test blueprint, that's the other synonymous term. We've had that since 1 or 2 months ago. Binigay yan sa mga school administrators. I'm a school administrator myself. So I've received a copy of that, okay, 1 or 2 months ago pa. Okay? Ngayon, medyo kumalat na sa mga estudyante and they're worried, Doc, dito ba i-base yung exams namin sa October 2023. Okay, first, ano yung test blueprint or table of specifications? Basically, it tells you kung ano yung plano nila for the board exams. Nakasulat doon yung mga topics or learning outcomes. And then, nakakategorize siya into yung sa Bloom's taxonomy, yung recall, understand, apply, etc. Naka-indicate din doon kung ilang points yung para sa topic na to, under recall, under understanding, under apply, etc. Okay? Ngayon, it's not the first time that they have done table of specifications. May table of specifications talaga kahit sa boards nyo. May table of specifications and blueprints na, okay? Even before our time, noong 2005, when we took the med boards. Okay, now here's the problem. Doc, bakit hindi nyo incorporate yung table of specifications to our program? Hindi po ba dadali ang buhay namin kung naka-base sa table of specifications na ginagamit sa boards? I honestly wish that they will actually use the table of specifications, this test blueprint, for your boards. Okay? But there are systematic problems kasi with that, with our laws, and with the table of specifications itself. So this is based on my personal opinion. First problem is quality assurance mechanisms were non-existent in 1959 when the Medical Act was created. So you can have this test blueprint. There's really no checker, no quality control, quality assurance mechanism to ensure that the table of specification is being followed. This is not the fault ng Board of Medicine. It's an inherent fault or weakness doon sa batas natin for the board exams. So there's no real motivation because there's no checker really to ensure na nasusunod yung table of specifications na yun. Second problem with the table of specifications is that the concepts are too general and the references are not cited. I wish they will say, okay, for biochem, we will get the questions from the following books or the following practice guidelines. For IM, we will get them from the following textbooks, the following websites. Walang ganun eh. Okay? The concepts written there, yung mga learning outcomes na gusto nila, are general, hindi siya ganun ka-specific. Nako-cover din natin talaga sa top-notch. Okay? Pero hindi siya yung, okay, they're going to ask the diabetes mellitus pathophysiology 2 points. Hindi ganun ka-specific eh. Okay, based on the ADA guidelines, hindi ganun ka-specific yung ginagawa nila dun sa table of specifications. So, dahil siya ay general, hindi specific yung mga outcomes, walang quality control mechanisms to ensure compliance. Okay, at hindi nakalist yung references. For your batch, we decided not to bother you, not even to inform you that there's a table of specifications, okay, that came out. There's a new table of specification. Lumabas yan 1 or 2 months ago in preparation for universal healthcare, UHC. So basically, ang ano na yan, test blueprint na yan, it's going around now to the various medical schools para actually not for the board review, it's really for curriculum planners para maayos halimbawa yung curriculum ng med school from 1st year to 4th year to align with the med boards, to align with their plans for the med boards based on that UHC. So, Doc, magbabago ba ang aral namin based sa kumakalat na table specifications na to? I certainly can't stop you from taking a look at it and trying to design your study based on the table of specifications. You can, but I wouldn't recommend it personally. Kung kapatid ko kuha ng exam, di ko ma-recommend guys kasi may table of specifications na even before, even 20 years ago. And we've been monitoring the board exam questions, sources, content. Hindi siya, I wish they would really just follow that table. Okay, to be honest, I really wish they would. If in October, they actually 100%, even without quality control mechanisms, they followed it, okay, entirely, I'll be very happy. We'll be able to notice that based on the feedback of the students. So we'll make adjustments. But even if we do make that adjustment, more or less, na-cover naman natin. Yung kung titingnan yung table specifications na yan, na-cover natin yung sa top-notch, guys. So I wouldn't worry too much about it. So don't let yourself be stressed out by that TOS, the table of specification or test blueprint. Okay? Now, let's proceed to the clarifications and corrections for your surgery handout and video. Your surgery lecture was given by Dr. Lubomir Antonio. Isa lang, kasi siya yung pinakamagaling talaga. Okay, so pinili ko na siya lang mag-lecture. But your handouts were created actually by several people. Dr. Antonio is one of them, but it's mainly Dr. Mabugat, Dr. Ann Cocos, and Dr. Kurt Aspera. So there may be some differences. Okay, some of them are really differences in the opinions of these surgeons. So we'll discuss them to you, okay, along with the corrections. Sige, so get your handout. Okay, I'll give you time to write. Okay, I'll take it slow. Okay, para ma-ano ninyo. Page 2, left lower quadrant, there's a duplicated guide question. Correct question is in the video. Okay? So may na-duplicate na guide question. So there's a problem from the media team, the one who does the layout. So napagalitan sila. May nakakalusot pang ganito. Pasensya na guys for that. Okay, so duplicated guide question. Just follow. Okay? Place an asterisk in your handout. Follow the one in the video. Okay? Next. Page 4, okay? For protein requirement, okay, we actually gave you a range 0.8 to 1 gram per kilogram per day. So I think there was a question in your handout na, Doc, pwedeng applicable yung 0.8, pwedeng applicable yung 1 gram. Ano po yung susundan natin? We verified this with Dr. Antonio. You follow, okay, the upper limit. Okay, so for examination purposes, so follow yung 1 gram per kilogram per day. Page 4, right lower quadrant. Okay. Next. Page 8, right lower quadrant. Treatment of choice for VWF is purity factor 8 DDAVP. So for von Willebrand disease, von Willebrand factor. For VWD, von Willebrand disease, treatment of choice, purity factor 8 DDAVP. Okay. Next number. So this is just added. May nagtanong kasi, Doc, bakit hindi nagbibigay ng whole blood, MMA, etc., etc. So we actually had this clarified with Dr. Lu. So page 9, right lower quadrants. Okay, just add this now, okay, to your handout. Okay. The blood bank should strive to deliver plasma platelets and RBCs in a 1:1:1 ratio. Okay. The blood bank should have ready stock of 6 units each of RBC, fresh frozen plasma and platelets in a cooler for rapid transport. Okay? Kaya siya ginawang kung bakit hindi whole blood, kung bakit ganito, it has something to do with availability. So just add this to your handout. The blood bank should have ready stock of 6 units each of RBC, fresh frozen plasma and platelets in a cooler for rapid transport. Basic lab test should be done immediately on arrival sa emergency department. Suggested lab values, CBC, INR, fibrinogen, pH, NR based deficit, EEG were available and repeated as clinically indicated. So the highlighted portions, please add to your handout. Okay, next. Okay, this is something to do with Doc, greater than lang ba siya or greater than equals to? Okay, or less than lang ba or less than equal to? So, according to Dr. Antonio, okay, the proper values here is yung may greater than equal to, okay, or less than equal to. Hindi lang yung greater than less than. So just a slight modification to your handout, kindly follow this one. Okay? Page 12, left lower quadrant. Next number. There's a, from page 15, left lower quadrant, Venus axis row missing from the handout but is present in the video. So again, these are faults sa media team to. Okay? So kindly include this, okay, based dun sa video. So this is yung missing part na yun is found in the members video, okay, with this address. So venous access, 2 large bore needle, catheters for IV access, venous cut down, central line, intraosseous access. Pasensya na guys. Okay, na-miss to, napura. Pagdating dun sa handout. Okay, ready? Next. Okay. Page 20, left lower quadrant. Hard signs and soft signs for vascular injury. Okay? Iba yung nakasulat sa Schwartz, tapos iba yung lecture ni Sir. According to Dr. Lu, honestly, sabi niya, mali yung sinulat ni Schwartz doon sa hard signs, soft signs. However, okay, for board exam purposes, even though mali yung nakasulat sa Schwartz, yun yung susundin. Okay? Dahil malamang yun yung susundin pagdating sa med boards. Okay? So we've added here a yellow box to explain this. This is based on an actual table from Schwartz and should be followed for exam purposes. However, significant hematoma and palpable thrill or bruit are actually considered hard signs. So yun yung tama, mali si Schwartz according to Doc Lu. Okay? So kindly indicate this in your handout. We will follow Schwartz. Next. So kindly add an additional row, page 21, right lower quadrant for Piedmont fractures. Piedmont fracture, fracture of the radial shaft at the junction of the middle and distal thirds without an associated fracture of the ulna. Okay, next. Okay, regarding the Parkland formula, okay, so we follow the latest recommendation from the American Burn Association and ATLS. Okay, so this one is what we're going to follow for your exam. Okay, next. Page 31, left lower quadrant. So here's a correction at the level na ni Doc Lu. Okay, remove done in toxic, non-toxic multinodular nodule. Okay, treatment for multinodular nodule is total or near total thyroidectomy. Okay, next. Okay, taller than wide. So copying error. Okay. Taller and wide should be an ultrasound feature under malignancy in a thyroid nodule, not the cervical lymph node. So thyroid nodule dito dapat. I think initially nandito siya sa column na to. Dapat ilipat niya dito sa kabila. Page 33, left upper quadrant. Okay, next. Okay, yung size. Okay, page 33, right upper quadrant. I think yung iba kasi ay 4, yung iba ay 1. Nalito yung mga estudyante. So we clarified this with Dr. Antonio. Okay, ang instructions niya, in practice, kahit nakasulat na 4 yan, in practice, we follow a tumor size of less than 1 centimeter for lobectomy and hysterectomy. So kahit nakasulat 4, which is tama din naman, okay, in practice, okay, less than 1 na sinusundan. Okay, next. So slight change lang. Okay, napaka-OC ng mga nag-submit nito. Page 35, right lower quadrant. Okay, extends from the base of the skull, not off, but to. Okay, from base of the skull to the sacrum. Page 35, right lower quadrant. The Batson vertebral plexus extends from the base of the skull to the sacrum. Next. Page 38. Okay, this is something to do with the difference na ni Dr. Lu and the other authors nung handout ninyo. So they cited different references. Kaya mayroong, tignan nyo to, page 38, right upper quadrant. Okay, may nakasulat na 66%, may nakasulat sa PowerPoint niya, I forgot which is which na 90. So ano yung susundan? Susundan natin yung sinabi ni Doc Antonio. Siya pa rin talaga yung gold standard dyan. So we're going kindly change our handout to 66%. Okay, next. So page 72 for surgical shunt versus tips. So kindly change this. Refractory bleeding, child A or B, surgical shunt, child C, tips. Okay, next. Page 110. Okay. Iba ang, this is a guide question. Magkaiba yung sagot ni Dr. Ann Cocos and ni Dr. Lubomir Antonio. Dr. Ann Cocos is one of our teachers for top-notch Genesis sa surgery. Top 1 ng board exams niya. Ganon din si Dr. Lu, top 1 din naman ng board exams niya. Both are surgeons and both have different opinions regarding this question. So actually, there are several students who asked me, Doc, ano yung tamang sagot? Okay. Magkaiba. Iba talaga yung sagot ni Ann at ni Doc Lu. So we actually, for the next batch, we're going to print both of their explanations. But we're going to side overall with Dr. Lu. Okay, siya pa rin talaga yung gold standard. Okay, so this is pseudo-obstruction. If you look at your handout currently, Dr. Ann Cocos gave a very detailed explanation on kung bakit sa tingin niya letter D yung sagot. Okay, but may explanation din dito si Dr. Lu. So it's a matter of professional opinion. Overall, we will follow itong kay Dr. Lu. Okay, although for the next batch, we will actually print both of their individual explanations to this one. So bakit pseudo-obstruction? Rectum distended and have hypoactive bowel salts rather than hyperactive. Okay. Next number. Okay, that's it. Let's do now the clarification. So, tama yung nakasulat, pero yung mga students get confused over the concepts written dun sa handout. So, we need to further explain them. Okay, so, on the guide questions for protein requirement in surgical patients in high stress. So, page 5, left upper quadrant. Go back. So, again, this is the application of yung upper limit, yung ginagamit, the one I told you earlier. Okay. So letter D is the answer. Okay. So we use the upper limit in computing. That's why the correct answer is 2.5 and not 2. So this has been verified with Dr. Lu Antonio. Okay. Next. Go to page 10. Why do we limit female donors in the prevention of TRALI? Okay. We limit female donors according to Dr. Lu. Okay, and Dr. Frins, actually tumulong din dito, Dr. Frins Rubio. Higher donor white blood cell antibodies in females. Since especially those with multiple pregnancies, they have higher levels of antibodies secondary to their immune system reacting to their babies in the uterus. Okay? So why do we limit female donors in the prevention of TRALI? Next. On tracheostomy, page 15, left lower quadrant. Okay. So the question here by the student is, bakit hindi Doc letter B yung sagot? Bakit letter C? Okay. So B is incorrect since there is no need for tracheostomy. In a patient who obviously has tension pneumothorax, needle thoracostomy must be done. So this is the answer given by Dr. Lu Antonio. So bakit hindi letter B? Okay, no need for tracheostomy. Patient obviously have tension pneumothorax, needle thoracostomy must be done. Next. Okay, on multiple injuries, page 13, right lower quadrant. yung sequence ng pagpa-priority doon sa titirahin. So, according to Doc Lu, hindi magbabago yung order. Okay? No change in priority even if a major arterial supply in the limbs is present. Okay? So, ito pa rin, nakasulat. Diyan sa handout ninyo. Tama pa rin yun in terms of order of priority. Okay? Next. Next zoning, page 22. Okay? This is actually indicated in your Doc, bakit magkaiba yung zone sa neck between anatomy and surgery? Napansin na rin yan ng mga anatomy teachers ninyo. Actually, I think may yellow box dun sa anatomy handout nyo explaining na magkaiba talaga yung zones for anatomy versus for surgery. Okay, magkaiba talaga. Noted na yan. Okay, kahit noon pa. Okay, this is not the first time this was asked. So what should be followed though? Follow the one for anatomy written in the anatomy textbooks. Follow the one for surgery written in the surgery textbook. Parang sa ano to may similar issue kami sa pharma and sa physio. In terms of yung mga adrenergic receptors na ginagamit per site, kung titingnan niyo yung table ng Katsung versus table na nasa Guyton tsaka per, magkaiba din yung guys. So I tell my students, you follow yung table na nasa Guyton at nasa Burn for physio. Basically, follow physio textbooks for physio. Follow pharma textbooks for pharma. Okay, yung differences na yun, meron, makikita yung nagre-reflect din sa handout natin. Ganon din dito sa zone sa neck. Magkaiba talaga yung nakasulat for anatomy and surgery. Okay, you will have to follow differently from anatomy. You have to base it dun sa anatomy handout nyo. For surgery, following sa surgery handout nyo. So, lagyan nyo ng asterisk yung nasa page 22, yung mga neck zoning na yan. Next. Okay. Page 23, right upper quadrant. Okay. So, again, we mentioned this earlier. Follow. Okay. Different formulas are presented in the handout and video lecture. So, follow the one in the handout. This is the latest recommendation from the American Burn Association that is also used by ATLS. Okay? So, this is from Dr. Antonio. Sundin yung nandun sa handout. Next. Page 39, left upper quadrant on mammogram. Ultrasound for younger age group, younger than 40. Okay? Younger patients have a more dense breast. Okay, there's limitation of using mammogram. So tama yung nakasulat. So explanation lang kung bakit ganun. Okay? Next. Okay, page 39, left upper quadrant. Doc, bakit magkaiba ang treatment na nakasulat sa pharma versus treatment na nakasulat sa surgery? So for pharma, it's omeprazole, bismuth, metronidazole, tetracycline. And then for surgery, omeprazole, bismuth, amoxicillin, clarithromycin. So according to Doc Lu Antonio, both are correct and both are acceptable. Okay, so you can follow any of these. Okay, for your boards. Probably for pharma, I will follow the first one. Okay, and for surgery, I will follow the second one. But both in clinical practice are actually utilized. Okay. Next. Okay. On the anatomy of the spermatic cord, okay, again, a difference in anatomy versus surgery, surgery handout versus the one in the surgery lecture. Instruction of Dr. Lu. Okay, I think this has something to do with that inguinal nerve. Okay, you follow the one in the surgery handout. Okay, so for this one, follow the one in the surgery handout. Okay, not the surgery video. Okay, next. Okay, on morphine as pain management for acute pancreatitis. So there are contradicting statements in page 79 and page 87 of your handout. Okay, so Dr. Antonio has to explain this. Let me read verbatim. Yes, there is no evidence that morphine does cause a spasm of the sphincter of OD. I mentioned it because it was a common knowledge that it is contraindicated as an analgesic for cholecystitis due to that effect. And the use of morphine as pain management for acute PAM. Okay, next. For annular pancreas treatment, page 85 and 86. Okay, let me read verbatim from Dr. Lu. Duodenal duodenostomy, duodenal jejunostomy, and gastrojejunostomy are all acceptable options since all will bypass the annular pancreas. A duodenostomy, though, is the simplest and most readily accessible. Okay, next. Imaging on appendicitis in a pregnant patient, page 101, right lower quadrant. Okay. The recommendation for imaging is MRI in the OB handout, but ultrasound in the surgery handout. So may difference between the surgery and OB handouts ng top-notch. So magkaiba. Ano yung susundan, Doc? For Doc Lu Antonio, use ultrasound since it is more readily available than MRI. So more practical approach, use ultrasound, according to Doc Lu, because it's more readily available than MRI. Okay. Next. That's it. Okay. That's it for the surgery clarifications, connections. Okay. May mga questions pa na I think hindi pa nasasagot ni Sir. Okay, subukan ko na lang ihabol bukas. But I think we've discussed probably 95% of the questions submitted to us. So thank you very much. We apologize for extending so much for tonight. Okay. Di bali, maganda naman yung binigay din sa inyo ni Doc Mabugat kanina. We still have a Quizmasters. Let's proceed na, Dr. Kimi.
Yes, Doc. So I'll be flashing. Guys, we'll have a pre-test, 10 items. So get ready. Yung quiz, ano niya, quiz sheet. Okay, for question number 1. The surgical incision in an elective laparoscopic mesh hernioplasty for non-incarcerated inguinal hernia is classified as what type of operative wound? Question number 2. Which of the following is not a component of the Sears criteria? Question number 3. KJ, a healthy 26-year-old female, was stabbed by Reina. She arrived in the ER lethargic with cold and clammy extremities, and you note a stab wound on her anterior abdomen. Results of initial lab tests are still pending. After attending MD, When will you order a blood transfusion? Number 6. Question number 7. Number 8. Question number 9. And lastly, number 10. Hey, time's up. Let us now call on our Quizmaster for tonight, Dr. Justin. Doc,
Hey, Doc. Doc,
Doc, you may share.
Doc, I'm rinig naman po ako. I'm clear naman
Yes,
po.
Doc. You're clear naman po.
Okay. Sige. I'll share screen
You-
na po. Let's
Okay.
start the session.
Thank you, Doc.
Sige, Doc. So, good evening, everyone. So, I'm Doc Jazz Dogonon. I prepared 10 questions for you. So, nasagutan niyo naman. So, tama, Doc, na magpapapoll lang, a few seconds lang kasi nag-answer na sila and then I proceed to the explanation po.
Yes, Doc.
Okay, sige po. Sige, Doc. So, let's start with question number 1. So, surgical incision and elective lap measure neoplasty for non-incarcerated inguinal hernias is classified as what type of operative wound? So you have a few seconds to answer. Okay, so all right, so the poll ended. So very good. Around 80% of you answered letter A, 19% letter B, so and 1% answered letter C. So the correct answer here is your letter A. No? So let's discuss back it. So again, for the boards, tables are very high yield. No? So a lot of information can be crammed within the rows and columns of a table. For me, maganda na basahin niyo talaga yung mga tables, okay? So if it's too complicated for you, my tip is to simplify things, okay? So if it's an info overload, so simplify it. Okay, so this is what I did, no? So you may take a screenshot if you'd like. So there are 4 classes of operative wounds, no? So parang progressively dumadami yung checks, no, per category. So for class 1, there's no entry into any of the genital urinary, gastrointestinal, or respiratory tract. There's no inflammation and there's no infection. So basically, it's atraumatic, it's uninfected, it's a clean site. No? So an example of that is your laparoscopic mesh hernioplasty. So your inguinal hernias, no, they're classified as class 1 operative wounds. So bakit? So parang if you scrubbed into a hernioplasty before, you're just shoving in the bowel that went through the defect, no, in your abdominal wall back into the abdominal cavity. So you didn't enter it, hindi mo na siya binuksan. Okay, so there's no entry into the gastrointestinal system. Kaya it's classified as a class 1. Okay, so for class 2, clean contaminated, there's already entry into these 3 hollow viscous of the body. No, so as we know, there are normal, no, flora within these compartments. Kaya siya parang clean contaminated because there's normal flora already. Okay, so these includes your colorectal surgeries, no, but there's a higher infection risk in there. So note that lang. Okay, so for class 3, no, so there's entry into these tracts already. There's also accompanying inflammation, okay? But there's no pus, so it's not yet infected, okay? So other notes, no, includes mga foreign material or new trauma. So those are also contaminated wounds. And lastly, a dirty wound, no, so it's already infected, it's already purulent. Okay, so I hope that helps, no? So that table kasi is very high yield, so I hope you can also check this table, no? But if it's too on for overloads, again, I simplified it for you, okay? So let's proceed to the next question. So, which is not a component of your series criteria? Okay, so a few seconds to answer our poll. Okay, so very good, no? The overwhelming majority, 87%, answered letter D. So that is the correct answer. So again, I think Doc Pat Magugat emphasized this. In the Sears criteria, BP is not a component. So what is the Sears criteria? So the Sears criteria is your systemic inflammatory response syndrome. There are 4 parts to this criteria. So it includes temperature, heart rate, respiratory rate, and the WBC count. Okay? So importantly, BP is not a component of the Sears criteria. Okay, so there are other criteria na pwedeng mapagbabaliktad-baliktad nyo. So I've summarized again in this table. No? So for the Sears criteria, again, no BP. So temperature, heart rate, respiratory rate, and WBC ang mga components natin. Just go through the numbers. No? For the Q SOFA, there are 3 components. No? So your respiratory rate, your BP, so may BP sa Q-SOFA, pero wala sa Sears criteria natin. Okay? And lastly is altered sensorium or decrease in GCS. Okay? And your SOFA scoring, so it involves 6 components, no? So it looks at your respiratory, your hematologic, your cardiovascular, your neurologic, your gastrointestinal, which is your bilirubin, and lastly is your renal, no, through your creatinine or your urine output. Okay, so you can browse these figures, memorize din yung numbers, no, or at least na-differentiate nyo and makita nyo yung differences ng Sears, ng Q-SOFA, and ng SOFA score. Okay? So, again, for Sears criteria, walang BP criteria. Okay. Sige. So, next question. So, KJ, sinaksak ni Reyna, arrived in the ER, lethargic, cold and clammy extremities, with a stab wound. So, when will you recommend a blood transfusion? Okay? Sige, try nyo sagutan. Okay, so thank you for answering. So kalat-kalat yung mga sagot, no? So 45% answered letter A, so only when hemoglobin drops to less than 7. 22% answered letter B, so less than 8. Whereas 29% answered letter C. So very good to the 29% who answered letter C. That is actually the correct answer. So this actually went out, a similar concept was asked, no, in our board exams. So the correct answer is letter C. So bakit? So this question is kind of leading you towards, no, the hemoglobin cutoff that we all know. It's around either 7 or 8. However, there are caveats, no, to the hemoglobin cutoff that we usually know, which is 7 and 8. So we'll discuss that. So what are the general indications for transfusion? So the first is to improve your O2 carrying capacity of the blood. So when anemia is already symptomatic, some of the patient complains of exertional chest pain, exertional dyspnea, or pre-syncopal symptoms, we already request for blood transfusion. Next is for the treatment of severe but asymptomatic anemia. So the usual thresholds that we memorize now are 7 and 8. Okay, but however, the caveat there is it's supposed to be a hemodynamically stable patient. So again, si KJ, so sinaksak na siya. Tapos, nag-lethargic na si KJ. So is that hemodynamic stability, no? So she won't qualify for that. However, KJ qualifies for transfusion bucket. It's for volume replacement in the context of trauma. So baka kasi dinudugo si KJ sa loob. Okay, so when blood loss, more than 25% of the total blood volume is lost, that already qualifies for hemodynamic instability, and that is the criteria. Bakit we need to transfuse for KJ, okay? So this question is leading you towards the answer na 7, but remember the clinical context ng patient. Yung 7 na yan is only for hemodynamically stable patients, okay? So for the classes of hemorrhagic shock, again, 2 high-yield tables, no? Maraming makukuhang questions yung examiners, a lot of information to digest. If it's too complicated, simplify natin. Okay? So Doc Pat Mabugat, again, made a very good mnemonic, no? So the percent blood loss in hemorrhagic shock, that's just, remember a game of tennis? So love 15, 30, 40. So 15%, 30%, and 40% are your cutoffs. And to simplify and integrate everything, I've made this table. You can screenshot if you'd like. So for the clinical findings, very important to note, for class 2 hemorrhagic shock, the first manifestation is actually tachycardia. So sa class 3, hemorrhagic shock ka lang nagkakaroon ng decrease in BP. So the body tries to compensate by increasing the heart rate to improve your mean arterial pressure. Okay? So sa class 3 ka lang, if it's lumalala na yung blood loss mo, dun ka lang nagkakaroon ng decrease in BP. And lastly, if class 4, like KJ, no, she already has altered sensorium. And again, yung percent blood loss mo, log 15, 30, 40. So Doc Pat made another mnemonic, yung i-half mo lang daw, you get the total amount of blood loss. But what I like to do is, diba, the normal body, the average human being has around 5 liters of blood. So just multiply 5 by 15%, by 30%, by 40%. You get these values. So 750 ml, 1,500 ml, and 2,000 ml. Okay, so in the intervention, so you try to start first crystalloid resuscitation, especially since blood products aren't always available. But when it's already class 3, no, you already consider a pack RBC transfusion. Okay, so class 3, give RBC, 3 letters for class 3. And lastly, for class 4, a lot of blood has been lost, more than 40%. You already consider your massive transfusion protocol, where you transfuse a 1:1:1 ratio of your pack RBC, your fresh frozen plasma, and your platelet concentrate. Okay, so that summarizes the concepts for hemorrhagic shock and went to give blood products. Okay? Sige. So there are no questions. Let's proceed. No? To question 4. So Javier Alfonso, 32 male, 60 kilograms, nasunog, had third-degree burns over right forearm, second-degree burns over anterior chest and abdomen, and first-degree burns over the face and left arm. Based on Parkland's formula, how much fluid should be given the first 8 hours? Okay, so kalat-kalat ulit yung magasagot. So let's answer. So remember in your board exams, they ask you to bring a calculator. So for me, I brought it all 4 days of the PLE, just in case there are questions like this where I need to solve na. Okay, so 18% no answered letter A, 45% answered letter B, 27% C, and 10% letter D. So very good. The majority of the class got the correct answer. That's your letter B, 2,700 ml. Again, let's discuss fluid resuscitation in burn. So burn patients need a lot of fluids because of the destroyed yung skin mo, destroyed yung epithelial barrier, they will lose a lot of fluids. So in the Parkland's formula, we use the formula 4 ml times the kilogram body weight multiplied by the percent total body surface area. The total of this will be given throughout your 24 hours. And again, note, this was emphasized by Doc Broly and Doc Pat Mabugat earlier. There's a difference between the Parkland's formula. It uses higher number 4 kesa the more recent ABA recommendations and modified Parkland formula. It uses 2 only. Okay, so in the total ml and first 24 hours, half of it is given in the first 8 hours, and the latter half is given in 16 hours. Now, this is what the question is looking for. So we will solve for that. Now, you already have this, no? So how do you solve your percent total body surface area involved? So for estimating percent total body surface area involved, there are various tools that you can use. So the easiest one to memorize for the board exams is your rule of nines. Okay, so the body is divided into 11 regions, where each region has 9%. No, so the head, the chest, the abdomen, each arm is 9%. So the thighs each one is 9%. The lower legs are also 9%, and the remaining 1% is in your genitalia or perineum. Now the Lund-Browder chart, it's more accurate, especially for pediatric patients, but it's too complicated. Hindi mo siya madaling magawa on the fly. And lastly, the palm method. So 1% of the patient's palm is approximately, the size of the patient's palm is approximately equal to 1% of your total body surface area. An important caveat with the percent TBSA solving is that first-degree burns are not included. So yung mga superficial burns mo, for example, yung mga sunburns mo, they're not included in solving it. Only second and third-degree burns are included. Okay, so let's solve. So see Javier Alfonso, he has a third-degree burn of the right forearm. So that's like half of your arm. So 9% yung isang arm. So divide by 2 kasi forearm lang. So 4.5%. And then second-degree burn over the anterior chest. That's 9%. Abdomen, 9% again. So first-degree burns not included. So total is around 22.5%. So just plug in the values into the formula. You get 5,400 ml in 24 hours, half of that in the first 8 hours. That's a total of 2,700 ml. Okay, so I hope that's clear yung difference ng Parkland's formula sa bagong recommendations ng American Burn Association. Okay, so we use lower thresholds now to avoid overhydration and the risk of pulmonary edema. Okay, sige. So next question tayo. So the initial diagnostic test in the palpable solitary thyroid nodules. All right, so very good, no? 71% of the class answered letter C. A few answered letter A, B, and D. So 5%, 18%, and 6%. So very good. The majority of the class had the correct answer. It's your serum TSH. Okay, so the initial diagnostic test is your serum TSH. And here are your algorithms, no? So in your handout, it shows here that TSH test is the first one. Why is it important by the first? No, because you want to determine if the patient is euthyroid or even hypothyroid versus a thyrotoxic patient. So when the patient is thyrotoxic, you want to do a radionuclide scan. Bakit? 2 reasons. First is that you don't want to biopsy or touch a thyrotoxic thyroid kasi it is very vascular. And when you biopsy something very vascular, what's going to happen? There's a risk, no, of hematoma. There's a risk of bleeding, and it's in the neck, no? So it can result in airway compromise. Secondly, if it's a hot nodule, almost all hot nodules are not malignant. So pag hot nodule, usually pinapabayaan mo. It's probably not going to be cancer. Okay? So if the question naman is, what is the single most important test in the evaluation of thyroid nodules? So you can type in the chat quickly. What do you think is the answer? So sige, in the interest of time, the correct answer here is actually your FNAB, your fine needle aspiration biopsy. So, all right, very good to those who answered. So FNAB is the most important test. So again, initial diagnostic is your TSH test. Most important diagnostic is your FNAB. So bakit siya most important? So if you recall, your Bethesda classification, it's a cytopathologic classification system. So based on the Bethesda classification, you know what are the next steps. No? So is it likely malignant? Is it not likely malignant? Is it just a cyst? Okay, so with that, you know what additional steps to do. Okay, so very good in the class. You got the correct answer. So next question. So Christine Joy has our inflammatory breast cancer, no palpable nodes, no focal neurodeficits, no bone pains. So what is the probable clinical stage? All right, so thank you for answering. So the majority of the class answered letter A, 46%, 17% answered letter B, 23% letter C, and 15% letter D. So it's okay. This is a difficult question, breast cancer staging. So if there's anything I want you to get from my lecture, I hope I can help you with breast cancer staging. So the correct answer is actually letter C, stage 3B. So for inflammatory breast cancer, it is automatically stage 3B. So bakit? So again, inflammatory breast cancer, no? So there's already involvement of your dermal lymphatics, no? And the manifestations are various skin changes. So diffuse erythema, thickening, a prudy orange appearance, no? So because of lymphatic edema. Okay, so it's already T4D disease, and when you have a T4 disease, that is automatically stage 3B. Bakit? Kasi based on studies, we know that it has a poor prognosis. So it's already considered a low regionally advanced breast cancer because there is underlying lymph node metastasis and even distant metastasis. All right, so cancer staging to familiarize or memorize, probably ito yung basic 3 na malaman nyo. If you can do more, well, good for you. So for thyroid cancer, yung mga well-differentiated types that includes your papillary, your medullary, your follicular carcinoma. The key concept is that the most important prognostic factor is your age. And the magic number in thyroid cancer, that's your age less than 55. So for patients who have well-differentiated thyroid CAs who are age less than 55 and low risk, even if there's distant metastasis, it's only stage 2. The rest, stage 1. Diba? Okay, for colorectal cancer, though the T staging is important, so it just follows your 4 layers of the colon and rectal wall. So from involvement of your mucosa, submucosa, your muscularis propria, and submucosa, and serosa and beyond. Okay, so but it goes deeper and deeper kasi. And lastly is your breast cancer. Probably the most difficult, but let's try to simplify it later. Okay, so the key concept is that axillary lymph node status is your most important prognostic factor. Okay, because it determines risk of recurrence. If it's node positive, up to 70% are recurrence. If it's node negative, more around 25 to 30% lang. Okay, so breast cancer TNM staging. Again, if there's something you want you to know, siguro ito yung sana madagdag ko sa arsenal nyo for your boards. Okay, so magic number TNM staging. So for the tumor, I want you to memorize 3 things only. 2 magic numbers, 2 cm, 5 cm, and if there's local invasion. So T1 is less than 2 cm, T2 is between 2 to 5 cm, T3 is larger than 5 cm. So it's T4 already if there's local invasion. So the chest wall to the skin. So for example, yan is your inflammatory breast cancer. Kaya siya T4 already. So for your N, no, so your nodal status, so parang pag ganyan siya. From your kilikili, paloob, and pataas. Okay? So your axilla or your kilikili, no, so if it's N1, if it's only movable and ipsilateral, N2 siya if already fixed or involvement of your internal thoracic, N3 if both the kilikili and your internal thoracic already have palpable lymph nodes or even beyond that. So sa neck na, supraclavicular or cervical already. That's N3 disease. And M, pretty basic lang, no? Distant metastasis or wala. Okay, if M1. Now, I'll also teach you the magic hands, no? Thank you to Doc Mark Milan, who's also used to teach in Top Notch ATA, and one of the people I look up to in terms of being an educator, okay? So, for breast cancer staging, all I want you to do is, sige, with me, no, raise your hand, no? So, you label your hand T1 to T4. So your thumb T1, your index finger T2, T3, and T4. Okay? So you remember that. Next, also your nodes, no? So N0 at your thumb, N1 at the index finger, N2 in your middle finger. And you skip T4 kasi diba T4, the ring finger, it's only for one person only. So you skip T4, loyal ka kay T4. So N3 is in your pinky. So you only make you only wear a wedding ring or make a pinky promise with one person. So special si T4 and N2. Okay? And everything else, no, pag distant na yung spread, that's already M1 disease. Okay? Now, your exceptions, no, your palm, no. So you remember two exceptions. That's your Tito Nemo and Trinoma. Okay? So T3 N0 M0 and T2 N1 M0. Okay? So if you're Bisaya, it kind of sounds like Tito Nemo asa Trinoma. Okay? So that's how I remember it. So if you're a visual person, so choose any Tito. So since Gen Z ako, si Tito Mikey yung pinili ko. So si Tito Mikey, Tito Boy Abunda, or any Tito, Tito Soto in Trinoma. Okay, so that's in the palm of your hands. Now let's stage. No, so in your thumb, T1 and 0, that's stage 1 disease. Okay, in your index finger, stage 2A if it's T2 or N1, and these are the possible combinations. But remember, T2 N1, Tito Nemo kasi is an exception. So it's not stage 2A. It's already stage 2B. No? So your exceptions in the palm of your hand, that's Trinomo and Tito Nemo. That's already stage 2B disease. Okay, so in your middle finger, that's stage 3A. So T3 and or N2 disease. These are the possible combinations. So for any T4 disease, like our question, no? Stage 3B, so any T4 disease, that's already stage 3B. Okay? For any N3 disease, that's already stage 3C. And of course, if it's metastatic, that's already stage 4. Okay? So congratulations with your only your fingers and your palm. I hope that will help you, no, as a memory aid for breast cancer stage. Okay? So take a screenshot if you like. Go lang. I ask permission naman from Doc Mark Milan. Okay? So I hope that can help. All right? So if there's no more questions, let's proceed to the next question. So a unique complication of gallstones presenting as gastric outlet obstruction due to impacted gallstone of the pylorus. All right. So very good. 50% answered letter B, 41% answered letter C, and some 3% and 5% answered letter A and D. So here, very good. The correct answer is your Bovarez syndrome. Okay. So let's discuss the gallstone disease and its possible complications. So cholecystolithiasis just means you have gallstones, whether cholesterol stones or pigment stones in your gallbladder. And it may be asymptomatic or maybe presenting as symptomatic or chronic. So if you remember your biliary colic, that's its manifestation. When the gallstones result in inflammation, that's called your acute cholecystitis, resulting in inflammation of the gallbladder. Keyword here is your Murphy sign. No? So an inspiratory pause, it's RUQ pain pala. So an inspiratory pause kasi masakit yung gilid mo. Okay? And it may be due to stones or not due to stones, and maybe acute or chronic. So choledocholectasis naman, it just means there are gallstones sa baba naman, sa biliary tree, usually in your common bile duct. Okay? Acute cholangitis is when there's superimposed inflammation and infection of the biliary tree due to stasis and other possible microorganisms. Acute pancreatitis occurs when the gallstone is impacted on your pancreatic duct. Okay? Specifically at the ampulla obvator. And remember that it is actually one of the most common causes of your acute pancreatitis. So gated yung mnemonic, diba? So G is for gallstones, A is for alcohol, T is for trauma or hypertriglyceridemia, E is for post-ERCP, and I think D is drug-induced. Okay? Next is your Meretzi syndrome. So it's a special type of gallstones in your gallbladders. It's like a cholecystolithiasis, but uniquely, the gallbladder stone is impacted in the infundibulum, no, or in Hartmann's pouch, And because of this, it mechanically obstructs your CBD. Kaya similar yung manifestations niya as choledocholitis, where they may be jaundice. Okay, so gallstone ileus occurs when a gallstone impacts on your ileocecal valve due to a cholecystoenteric fistula. So there's a fistula between the gallbladder and your GI tract, no? So the gallstones travel down, resulting in intestinal obstruction or your ileus. Now, your Bovaert syndrome is a special type of ileus where the impacted gallbladder stone is in the pylorus or duodenum. So more proximal in the GI tract. And therefore, because it's in the pylorus or in the duodenum, it results in gastric outlet obstruction. Okay, so there are other complications here: mucocele, gallbladder perforation, your cholangiocarcinoma, porcelain gallbladder, strawberry gallbladder. Okay, so I'll leave you to review that. But yun, so Bovaert syndrome is a rare and special type of gallstone ileus due to a gallstone in your pylorus or duodenum. Okay, so last three questions. Cephalosis gene, a 58-year-old female with a groin bulge, which enlarges during a Valsalva. So if this were a femoral hernia, what is its NIHOS classification? Okay, so very good. 58% of the class answered letter D, and some, no, 18%, 9%, and 15% answered A, B, and C respectively. So very good. The correct answer here is NIHOS class 3C type of hernia. So that's your femoral hernia. Okay, so your groin hernias, no? This is the NIHOS classification, as what Doc Pat Mabugat's mentioned. This is an old classification already. However, our board of examiners still like this concept, no? So it's still a testable concept kasi. Okay, and my mnemonic for the NIHOS classification is NIHOS is indirect, but 3 and 4 differ. Okay, so isa-isa natin. So for NIHOS 1, it is I, no? So indirect. So parang Roman numeral 1 kasi it looks like an I also. So that's how I remember it. So 1 is indirect. So NIHOS 2, so 2 is also indirect, pero kasi dalawa na yung I, so it's like a bigger, no? So the internal ring is enlarged. So it's an indirect inguinal hernia with a bigger or enlarged internal ring. Now, 3 and 4, they differ. So hindi sila automatically an indirect hernia. So for 3, that's your diff, no? So 3A, 3B, and 3C is DIF. So 3A is direct, 3B is indirect, and 3C is your femoral. And 4, so differ, so R means recurrent. So again, NIHOS is indirect, but 3 and 4 differ. So that's my memory aid that helped me to memorize my NIHOS classification. Okay, so some questions, mabilis lang. So the most common subtype of groin hernia in women. So can you chat, no? Mabilis lang. So most common subtypes, some answered femoral, so some answered indirect. So very good. Here the correct answer. It's a trick question, no? So femoral hernias are more common in women, but overall the most common is still your indirect inguinal hernia. Okay, so indirect inguinal hernias pa rin ang most common, but women just have a higher risk of having femoral hernias. Okay, so trick question yan. Okay, so next, what's the treatment done for your femoral hernias? So, marami yan, mga Bassini, McVeigh, Lichtenstein. So, the correct answer, can anyone try? So, sorry, in the interest of time, the correct answer is your McVeigh repair. Okay, so for femoral hernias, so it's your McVeigh repair. And lastly, so a herniation of the vermiform appendix. So what is its eponym? So that is your ameian hernia. So again, I think Doc Pat Mabugat mentioned it again. Again, in the interest of time, you can just screenshot this. Balikan nyo na lang pag malapit na yung boards. Again, if you remember these hernia eponyms, makakalimutan nyo lang by the time the board exams happen. So siguro balikan nyo to in the second or third reading na pag malapit na yung board exams. But I hope these mnemonics can help. Okay, so take a screenshot now. So 5, 4, 3, 2, 1. Okay, and balikan na lang pag malapit na yung PLE surgery. Okay? Sige. So next question tayo. So, which is not an element of your modified or Alvarado scoring system? Okay, so very, very good class, no? So 84% answered letter D. Some answered A, B, C, 8%, 5%, 3%. That's okay. We'll improve on that. So the correct answer here is your letter D. Bakit? Kasi it's supposed to be shift of WBC count to your left. No? So a left shift, no? immature WBCs like your bands and stabs appear in your in your CBC, and that is a sign of inflammation. Okay, so a left shift of your WBCs. Okay, so the Alvarado scoring is a clinical scoring system to determine the likelihood of your acute appendicitis as a diagnosis. Again, the abdomen is a diagnostic black box. No, pag abdominal pain, pwedeng hindi pala appendicitis yung result. Kaya we're very careful. Most surgeons want a negative appendectomy rate of around less than 20%. So dapat sure ka or more or less guided ka na most likely appendicitis yung what you're dealing with. And the Alvarado score helps you determine the likelihood of this diagnosis. So your mnemonic is your Mantrels. So migratory right lower quadrant pain, anorexia, nausea, vomiting, RLQ tenderness, rebound tenderness, elevated temperature, leukocytosis, and a left shift, not a right shift. Okay. And important to note, tenderness in your right lower quadrant and leukocytosis are given 2 points. Okay. So again, Mantrels, and note which one is 2 points. Okay. So let's proceed to the last. Sorry, meron pa pala. So, mabilis lang, what is hypogastrik pain reproduced by passive internal rotation of your flexed right thigh? Again, so internal rotation of your flexed right thigh, what sign is that? That's your obturator sign. So very good, to those who answered. Thank you. So that is your obturator sign, okay? So again, here are, mahilig kasi talaga yung PLE natin with eponyms. There's just a fetish in medicine about these eponyms. Everyone wants to have a name for themselves. So again, if you remember this now, medyo malakalimutan mo lang din yan by board. So just make a mental note now. Babalikan mo yung table na to and try to familiarize or memorize these. Okay, so if there's 3 na wag mong kakalimutan, it's probably this, your Robsing, your ellipsoas, and your obturator sign. Okay, so your Robsing sign is if you palpate your left lower quadrant, may sakit ka sa right lower quadrant. Okay, so obturator sign, again, if you flex a passively internally rotated thigh, magkakaroon ng hypogastrik or right lower quadrant pain. And lastly, ellipsoid sign. So if you passively extend the right thigh or you ask the patient to actively flex the right thigh, it will result in pain. Okay, so makalimutan yung lahat, wag lang yan kasi ginagamit pa rin yung mga clinical signs niyo. Okay? Sige. So last question, it's been a long night, so last question tayo. So management of choice for your thrombosed external hemorrhoids, very painful and lasts only for 72 hours. Okay, so thank you for answering. So 56% answered letter A, 1% letter B, 21% C, and 20% letter D. Okay, so the correct answer here is kasi it's thrombosed and sobrang sakit, you need to excise it. Okay, so an excision hemorrhoidectomy. Okay, so let's review lang your anorectal conditions and their management. Okay, so external hemorrhoids. So normally, people do have hemorrhoidal cushions. Nagiging masakit lang siya pag symptomatic siya or masyado nang malaki. Okay, so external hemorrhoids, they occur below the dentate line and they are supplied by your, and they are lined pala by your anoderm and have a somatic innervation. Hence, they're very painful and itchy if they are thrombosed. So internal hemorrhoids naman, they're above your dentate line and they are insensate to most stimuli kasi more of endoderm pa yung lining niya based on your embryology. So they usually present as painless and bright red lower GI bleeding, especially when you poops. Okay, so there's a grading system from grade 1 to grade 4. So grade 1 does not protrude, grade 2 protrudes but nababalik naman on its own. Grade 3, kailangan mo ipasok sa loob. And grade 4, it's not reducible. So there's already a risk of strangulation. Okay. Next is your acute anal fissure. So usually this occurs in history ng patient, sobrang matigas yung poop nila, so they have constipation. And there's anal pain and lower GI bleed during stool episodes. Okay. And usually the location is in the posterior midline. Okay, so the usual location is your posterior midline. For chronic anal fissures, there's a classic triad to it. So there's the anal fissure, there's hypertrophied papillae, and a sentinel skin tag. And lastly is your fistula in ano. So it's a complication of an anorectal abscess. It's katagalan niya, so in its chronicity, it found a way to course through the skin through a draining fistula. Okay, I'd like just read up na lang on Goodsall's rules and its exceptions. Okay, for the management, For external hemorrhoids, if it's acute pa lang, no, less than 72 hours, thrombosed, 10 out of 10, anorectal pain, so you want to treat the patient, you have to remove that thrombosed part, no, through surgery. So an excision, hemorrhoidectomy. If more than 72 hours naman, medyo nag-subside naman yung pain, there's an option for conservative management. Next, for your internal hemorrhoids, no, for all grades, you do warm sits, bath, high fiber diet, and your topical anesthetics. But if it's still symptomatic or troublesome for the patient, you can offer these procedures. No? So rubber band ligation, photocoagulation, and sclerotherapy for grades 1 and 2. So yung mga napapasok pa sa loob ng anus. And grade 3 to 4, surgery for most, RBL or sclerotherapy for some. Okay? Kasi pag grade 3 or 4, pumapasok na siya sa baba. So yung rubber band ligation, so literally as its name implies, you put a rubber band at the base of the hemorrhoid. And if you can't do that for external hemorrhoids, so no matter how the question tries to steer you, no matter how much it leads you towards rubber band ligation, you kind of don't do that for external hemorrhoids. Because again, they're lined by anoderm already. They have sensate somatic innervation. So sobrang sakit na. Okay, so RBL isn't really an option for your external hemorrhoids. Okay, for acute anal fissures, again, parang sugat lang siya sa may puwet area. So you try to do conservative management, warm sits, bath, high fiber diet, topical analgesics, or topical botulinum. And for chronic anal fissures, you do a lateral internal sphincterotomy. Lastly, for your fistula in ano, so keywords, fistulotomy, aceton placement. So you place a drain, no? And eventually granulation tissue will fill up the fistula strap, or a lift, so ligation of an interfistula strap. Okay? So thank you for listening. So I think there are a lot of people who are asking me, so Doc, do you have any advice for board exam takers? No, so the PLE, it's around a 2 to 3 month review. And in most things in life, especially in our field, no, sometimes all you have to do is just show up. Okay, so kahit pagod na kayo, makinig sa mga lectures, kahit umay na kayo sa mga handouts ng top notch, just show up, no? So sit down in front of your table, try to read 1 to 2 pages, no? So just show up. Okay? So this is good PLE progress. So again, if tuloy-tuloy ka, very good, no? If kalahati lang, yung natatapos mo, that's okay. That's still fine for now, no? Mahabol pa yung mga backlog sa second phase ng program natin. So that's still good PLE progress. And if pawala-wala ka, for example, nabasa mo na pero nakalimutan mo, that's why we do a review. Okay? So we review you para hindi, pagdating na sa board exams, hindi nyo na makalimutan. Okay? So again, just show up, but if you need to, take a break, no? So recharge yourself. Okay? So para naman, yung cellphones naman natin, di ba? Hindi na natin ginagamit pag 10 to 20% na lang. So charge muna natin. So charge yourself every now and then. Spend time with your family. Spend time with your friends. Take a break, no? And enjoy your hobbies. So again, you can't treat other people pag hindi ka na tao. Okay? So thank you for listening. It's been a long night. So you deserve a well-deserved rest tonight. So if there are any questions, feel free to ask away.
Okay, thank you so much, Dr. Justin. So far, Doc, wala namang question on our part or in the chat box. So,
Okay, maraming salamat, Dr. Justin. Maraming salamat, Kimi. We'll see you. Pasensya na everyone for extending tonight. This has been our longest out of the 4 subjects so far. Okay? So, sulit naman, hopefully, for everyone. Okay, I hope natuto naman kayo. We'll see you all tomorrow at 8 a.m. for the Intro to IM. Tama ba, Kimi? IM
yes,
na tayo
Doc. Into to
tomorrow.
IM.
Yeah.
Yes, Doc.
Sige, masaya. Team-based ang IM natin. Isang buong team ng mga various lecturers. See you, everyone.
Yes, Doc. Doc, we'll add lang to the announcement. Guys,
Yes.
available na yung Pedia Google Forms, yung for on-site lectures. You may check it out and sign in for your available date.
Okay. Ang pedia teacher ninyo sa on-site, si Dr. Ian De Vera. Guys, magaling yun. Parang another Antonio in the making yung si Ian De Vera. Okay, so for those who are attending or are going to attend the on-site, sulit na sulit. Okay, yung lecture din naman niya is nasa online, wala rin namang problema. Okay, so for IM, the IM videos are actually already available since 9 p.m. kanina. So those who want to study in advance, pwede na kayong manood ng IM. Okay, kung tapos na kayo for surgery. Thank you so much. See you tomorrow, Kimi.
Thank you so much,
Justin, maraming
Doc.
salamat din.
Happy
Sure, Doc.
birthday.
Thank you, Doc. Happy
Good
birthday,
night
Doc.
po. Good night, everyone.